We haven't done any research on targeted gene therapy. So targeted gene therapy is used often for retinitis pigmentosa, and Moorfields have done a lot of work on RP65, which you may be well aware of, and targeted gene therapy in that sort of scenario. The research we're more interested, actually, if we're looking down the gene route, is prognostic information. So basically, if you've got a child with mosaicism or a high penetrant mutation, how many tumors are they going to get in each eye? So this is the thing that we've been looking at, and I could spend hours talking to you about that area, which I can't do for 12 minutes. But in a nutshell, you get 3 tumors in each eye if you've got a high penetrant mutation. If you've got a mosaic, it comes down to 1 tumor per eye. And we published on that last year in Ophthalmology Retina, if you're interested.
Thank you. Thank you. We move on to the last topic.
So we move on to the next topic. Dr. Manjushri Bhate is going to speak on restrictive strabismus. She is a consultant ophthalmologist with LV Prasad Eye Institute. She has done her fellowship training in Westmead Hospital, Children's Hospital, Westmead in Sydney. She has worked there for a while and now has repatriated back to India and is working with LV Prasad Institute. Her areas of interest are genetic eye disease, strabismus, and she's going to talk on her work on restrictive strabismus in particular, and generally covering the strabismus with limitations. Thank you, Manju. Take it away from me.
Thank you so much, Sumita. Am I audible and can you see my slides?
Yes,
Yeah.
Yes, we can see.
Thanks. So at the outset, I'd like to thank the Asia Pacific Society and AIOS for inviting me to speak today. And I'll be taking you through some aspects of restrictive strabismus. I have no conflicts of interest to declare. So as we all know, restrictive strabismus is an incomitant strabismus. It's commonly subdivided as fractures in strabismus, that is following orbital wall fractures, thyroid strabismus after glaucoma drainage device, which can affect the extraocular muscles and the motility, the scleral buccal surgery, or it could be an unusual congenital or acquired restriction. And we'll cover some aspects of fractures in strabismus, of thyroid, and as well as some an unusual acquired restriction. So this will just be a case-based approach. So let's start with the first case. So this is 8-year-old child, and he fell off his bike, which is common in this age group, and he had a white-eyed blowout fracture. As we can see here, he had acquired hypertropia of his right eye following a floor and a medial wall fracture. And here we can see that there's a large defect in the inferior wall, and there's also entrapment of the muscle, following which he had a fracture repair. And so he underwent and then was referred to the strabismus clinic and underwent an exploration with recession of the inferior rectus of the right eye. And so he had much better cosmesis, improved ocular motility, and a resolution of his diplopia. He did have some limitation of up gaze and down gaze, as we can see in this early post-operative picture. Our next patient is a young lady, and she had a craniofacial trauma, and she had a fracture fragment which was impinging on the optic nerve. And she had an extra large strabismus, as we can see in the primary position photo in the middle here. She's got a large right hypotropia. So she initially underwent the fracture repairs and then was referred to the strabismus clinic. So this sort of her story spanned over a period of almost 5 years. She initially had an inferior rectus recession with a single horizontal muscle, the lateral rectus transposed to the superior rectus. Her hypertropia, the strabismus, did reduce from an extra large size to a moderate to large degree. We can still see residual hypertropia here. And then she had another surgery to transpose the other horizontal muscle. And as we can see over here, she is fairly cosmetic, though she had really poor vision in the right eye following the trauma to the optic nerve. Our next case, so I'm just going to take you through, it's not always this fracture strabismus like a fairy tale. And so this is the fairy tale of Goldilocks and the Three Bears. I'm sure most of you would be familiar or have enjoyed it in your childhood. This was like one of my favorites. So it's not always a fairy tale, by which I mean that bears are not friendly. And this little girl, I don't know what she was doing with a bear, but she had a bear bite and she had a fairly disfigured eye and face after that. So this is a photo after a lot of her oculoplasty repair that she underwent with the oculoplasty team, following which she was referred for strabismus management. And as we can see here, she has a restriction of motility in her right eye in pretty much all cases, and also a restriction of adduction of the left eye. Following which the MRI, she was able to fuse with prisms though to a single image, and the MRI showed a normal architecture of pretty much all the extraocular muscles. There was some soft tissue hyperintensity, which was secondary to all the extensive surgery that she had. And then she underwent a strabismus surgery. She underwent a bilateral lateral rectus recession. We tried to see if there was a superior oblique, which wasn't found. And eventually, cosmetically, she was better, I would say much better than what she was to begin with. Although our Goldilocks was not quite there, but she was almost just right. So this brings us to one of our recent publications in JPOS, which is now online, which looks at the clinical profiles and the surgical outcomes of strabismus following orbital wall fractures. And this was a large cohort of 347 strabismus cases. Some of the salient features were that we had more of males affected. The orbital floor fracture was more common, followed by medial wall fractures. And the resultant strabismus was not just restricted, but also paralytic, and exotropia was more common, followed by hypotropia. And in the combined deviation, it was a combined hypo with exotropia, which we noted. So as we can see in some of these bar diagrams here, we can see that the floor is more involved and followed by the medial wall. And also in the deviation, it's the exotropia, the hypo and the exotropia, which is more frequent, followed by the hypertropia. And again, the exo, which is more common, commonly involved. Looking at the cases that went on to needing surgery, there were about 34 patients, almost 1/10 of the cohort, that underwent surgery for strabismus. And the preoperative diplopia from almost 80% was reduced to 15%. And again, the cases were a mixed bag of restrictive as well as paralytic strabismus. So again, this is just about the walls and the type of strabismus involved, and the detailed paper is online if anyone's interested. Moving on to the next common restrictive strabismus that we see is the thyroid strabismus. And thyroid eye disease is something that involves, or rather the sequelae of the thyroid eye disease involves the orbit, the extraocular muscles, and the eyelids. And the extraocular muscle involvement, again, commonly affects the inferior and the medial rectus. And so also all the other recti and the oblique, none is spared. It can be asymmetric, and very often the patient presents with a disturbing diplopia and an uncosmetic appearance. They've already had, if it's a tertiary care center, they've already had some sort of intervention, possibly by the oculoplasty team. And the aim as strabismus surgeons does lie in improving the and giving the patient a comfortable field of binocular single vision, both in primary as well as down gaze, and a reasonably good cosmesis. So this is actually one of my favorite patients. He's a 56-year-old gentleman, and he came with a very uncosmetic hyperdeviation of the right eye. So he had a thyroid eye disease. It was stable for over a year. He underwent orbital decompression of the right orbit, and according to him, this strabismus and double vision worsened after that. So he refused any surgery on the left orbit, like he refused a left orbital decompression. And as we can see the imaging over here, he's got like these massive extraocular muscles. And in his 9 position of gaze, his right eye cannot depress, his left eye he cannot elevate. And then so I tried counseling him. He refused surgery for the left orbit. So he underwent a staged procedure. He had a right eye strabismus surgery where the super tight superior rectus was recessed on a hangback suture. And the right eye medial rectus was also recessed. And he's still like this, much better cosmetically, and doesn't want any further surgery whatsoever on the left eye. I'm just going to wrap up with this last case. So this is a 3-year-old girl, and she presented with a subacute onset of strabismus. She was brought by her parents. They denied any history of trauma, and in her previous old photographs, she was orthotropic, as we can see over here. This is the photo of her on her first birthday. When she came, this was just before COVID lockdown. And so if we look at her 9-gaze position, that left eye is just sitting locked into, or rather locked down in that particular position. And she's unable to have any extraocular motility in that left eye. And this is her imaging. The imaging revealed a bulky inferior rectus with increased signal intensity, and with a sort of suspected provisional diagnosis of myositis, she was started on a course of systemic steroids. She did not improve, and then there was COVID lockdown, and she vanished for a long time. And after many months, she came back with a similar eye position, and then she was taken up for surgery, and she underwent a free tenotomy of the inferior rectus of the left eye and a medial rectus recession of the left eye. And she was much better cosmetically, though she cannot depress her left eye as much. So just to come to some concluding remarks, restrictive strabismus is challenging. It needs to be individualized to the patient and managed accordingly. The aim being to improve the field of binocular single vision, to improve diplopia, and to improve cosmesis when indicated. In surgery, it's important to try and relieve the restrictions as much as possible. And it helps to have a little go.
Manju, are you done?
I think she's lost connection, ma'am.
Oh, okay. Are there any questions for the?
As of now, we don't have any questions, but our speakers could definitely speak to each other or have any remarks. We've got approximately 6 more minutes left for the session, ma'am.
Okay.
I will just tell about the previous topic. I think we used to have more restrictive strabismus when implants were done for retinal surgery. Our center was known more for Boston scleral buckling. And nowadays with explants and more of gas and vitrectomy endo lasers, I think the incidence of restrictive strabismus following detachment surgery has come down a lot. So the idea of actually primarily, as she mentioned, is to give single vision on the straight posture and down posture, and less than of cosmetic. I think any other comments from you for the last paper?
I have one question for Dr.
Did I lose out
Yes,
in between?
yes, you did.
Because I'm not sure if.
Yes, you
Yeah,
did.
we did
okay,
lose.
so
We were lost.
I'm sorry. It's the internet connection. I'm so sorry.
Yeah, a couple of
Is there
minutes are
something you
still
want to-
there. You can
If you want to say anything, what?
Oh,
okay, you can conclude.
which slide was I on? The conclusion or
Conclusion side, yeah.
before that?
Conclusion slide.
Conclusion. Oh, okay. So it's nothing about the conclusion. I was just, I think, going to say.
Okay.
Sorry.
One question for Dr. Hunter. Is he there still?
Yes, I'm here.
Dr. Hunter, how early would you do a probing using a nasal endoscope?
Well, it depends on the case. If the patient is having the typical NLDO with no episode of an infection, basically I will defer till age 1. But nevertheless, if the patient is having some unusual features, a recurrent infection before age 1, I proceed to probing early on, because I feel I've encountered a couple of cases with anatomical variations or underlying nasal pathology, as I have shown in my talk.
Thank you so much. I think that's probably a consensus on that. Most of us would like to defer any GA procedure till they are 1. But there is a school of thought that you could do it without anesthesia. If the children are younger, you could probably immobilize them better and do it in the office. What do you think about that?
I typically do under general anesthesia, and I try to defer till age 1. But then if the patient is having recurrent infections or some unusual features, or not the typical cause of an NLDO that is caused by the obstruction of a valve of Hessner, then I will do an early intervention. I don't do the office-based procedure. Whenever surgery is needed, I always do under general anesthesia.
You are very well experienced. Actually, few cases we have had done outside, the cutting the medial rectus and also even one optic nerve. So I think anatomical, you'll have to be very sure before getting trained for this procedure.
Well, I think the endoscopic guide, the syringe and probing is very safe. But then what you are talking about should be about the FAST, functional endoscopic sinus surgery, or even endoscopic orbital decompression. But a simple, I do endoscopic decompression for thyroid eye disease myself. But then as an ophthalmologist, we are very well aware of all the orbital structures. I think all the so-called medial rectus transection, I believe that it's very likely from the non-ophthalmologist. I can assure you that ophthalmologist trained is highly unlikely for such an occurrence.
But
and then the worst case,
there's 2 cases. They're not done in our institution. They're outside.
The worst,
so it requires a lot of experience.
the worst case that was reported was endoscopic decompression that resulted in a evisceration. That was reported, I think, in JAMA a few years ago. Definitely, I concur with you that proper training is needed if you're going to do the procedure. But nevertheless, in congenital NLDO, if you are just doing endoscopic guide probing without endoscopic DCR, I think the risk is very minimal.
Okay. And one this thing to Rohit Sharma, that overnight, Rohit Saxena, overnight contact lens I did try. I think I had used PMMA lens, and one diopter flatter than the fattest meridian, and get a fluorescent pattern of 3-point touch like keratoconus, and retainer lens for some time. It's worked in low myopes. So overnight optokeratology does help. You did mention, but my personal experience, I thought I'd share.
Very, very interesting, sir.
Okay, I think on behalf of the Asia Pacific Strabismus and Pediatric Ophthalmic Society, I thank one and all the speakers who did a great job, and I should thank my associate, who Sumita Agarkar, in 24 hours time, I think she could fix up all the speakers. And I remember Coney Lay, I think way back 2000, I think I was in Hong Kong as a visiting scholar. Hope you remember me, Coney Lay. So nice to see all of you. And once again, thanks to Frank Martin, Namrata Sharma, and Rohit Sharma. Rohit Saxena also did help me quite a bit for this excellent session. It will be memorable, always to be remembered. God bless everyone. Thank you.
Thank you, sir. Absolutely a pleasure to be a part.
Thank you, everyone.
It's great to see all of you.
Thank you. Same here.
On behalf of the organizing committee, I'd like to also thank Dr. Sumita and Dr. Sudarshan ma'am for concluding the session on time. Thank you.
Thank you. Thank you.
The next session is going to be on international refractive surgery, which is going to be starting at exactly 7 p.m. IST. That's approximately 1 hour from now. I can see already we have Dr. Rupal Shah, who's our first speaker, who's already logged in 1 hour before. Thank you so much for being here. This is the time where we go offline and you can check your presentation if you're there. Dr. Rupal? Arya, we could go offline now and then get started exactly in 45 minutes.
Hello.
Hello, ma'am.
Yeah, can I join in 10 minutes time?
Yes, ma'am, you can. You've got exactly maybe say 45 minutes too. We're going to be starting in exactly 50 minutes from now.
Okay.
So you
And
could
my
take
talk
40
is
minutes.
first, right?
Yes, you're going to be the first speaker. In case if you would like to check your presentation, this is the right time to check your presentation if you would like to.
I'll just share my screen.
Yes, you can.
Yeah, just one moment, please. Are you able to see my screen?
Not yet, sir. Not yet, ma'am.
Okay.
Arya, the next session is at 7 or 6:30?
6:30 sir.
अच्छा मेरे को तो 7 o'clock दिख रहा
Now
है.
can you see my presentation?
No, ma'am. Just let me. Could you try it one last time?
I'll just do it once more.
Yeah. We have Dr. Chitra also joining in.
Even I would check my presentation.
Just one moment, Chitra. Okay.
Yeah.
I'm sharing my screen now.
Yeah.
Shall I also share the virtual background, ma'am, Dr. Chitra? I can
No.
share it on this chat itself.
Yeah, but I thought, why not I use this blur? I never do this.
Ah,
I'll have this.
My screen sharing is
as you wish.
Am I sharing my screen?
It's just share screen has started. We can see that Dr. Rupal Shah has started a screen sharing.
Yeah, but I can't see my. Is my presentation available? No. It shows here your screen sharing is paused. I'll stop share and share again.
Yes.
So now my screen is seen, right?
Yes, we can see an Excel sheet.
You
Now
can
we can see
also
the
see
presentation.
can you also see the slide?
Yes, but it's a little blurred.
It is, so I'm not surprised actually. Now is it okay?
Yes, ma'am. Now it's perfect. Now we can see the slides perfectly.
Okay. It's just taking a little while, I think.
Yes, ma'am. Yes,
I need
ma'am.
my internet a little better.
I understand.
Okay.
So we shall be
I'm
starting the
stopping the
session.
share now.
Yeah.
Thank you. So the seminar starts, the session starts at 6:30.
Yes, ma'am. So that's
So I'll
22
join
minutes
at
from now.
6:30 sharp.
Yes,
Yeah,
ma'am.
I'll
Hi,
share my
Chitra.
screen. Hi. I'll
Bye.
just share my screen and see why it's not sharing.
Dr. Rupal, I request you to be back online in the next 10 to 15 minutes, 5 minutes
Okay.
before 6:30.
I'll do that.
Yes, ma'am. Thank you.
6:20,
Why
I will join.
Sure. Okay, ma'am.
I'm not able to share my screen.
Ma'am, we could see your screen. Now we can see, Doctor. We can see
Yeah.
thank you slides,
You can see, no?
AI Foundation.
You can see, no, right?
Yes, now we can see.
Okay, thank you. Okay, done.
just a reminder, we shall be getting started in 14 minutes from now.
Hi, Rupal.
Hi, Namrata.
Hi,
Hi,
how are you?
Hi, Rupal.
All the ladies have joined in first, see?
Yeah.
They are the sincere ones.
Yeah.
We
How are
somewhere-
you?
Good, good. How are you?
Such a great show this is.
Oh,
Yeah, I know. Great.
So
show. That's what
creditable,
we
Namrata.
sometimes just take her for granted that she always do superhuman things.
no, it is not super. Come on, Chitra.
It's really creditable, Namrata.
No,
So good,
she-
yeah.
And she puts it so casually last minute, and it does as well as any other meeting. She has that shows how many hundreds of things she does side by side.
Chitra looking nice.
Very nice, Chitra. What have you?
I know you've done something.
You've
Oh,
done
I've
something.
lost weight.
Beautiful you're looking.
Looking very nice.
How much
Great.
weight have you lost? It looks also.
No, I just started losing this month. I just stopped rice and roti and I'll just have vegetables and salad. And so you feel full actually. And
You do.
so I think in another month I lose this much. Then after that, if I lose, I'll start looking old. Like women have to be balanced.
No, you're looking lovely today. Lovely. Partho,
Where has he joined?
he's joined, but I don't know whether it is Partho or Partho's clone.
Yeah, I can see his name.
His
No,
name,
no,
but he
somebody
would have
else, I think,
somebody
joins
else will open. He's a
first,
big
then he
man,
comes in.
no? Big
Yeah,
boss. Come
yeah.
in last minute.
Then he comes in later.
Yeah, it's like you send people to stand in the queue, no? For you.
But three of us will not do that. Would we?
But why? We got such a great chance to come in to talk to each other. I would not miss this for anything.
I know.
So
Namrata,
happy to see both of you.
when we went to this Amar Agarwal's conference, no? So we went with Rupal and Ritika in that banquet time and ate in one very exotic place.
Acha?
Very
We
nice.
went to Avartana.
Oh.
Beautiful.
All had gone the day before, probably. Very nice. It was.
I just like to talk to you both so that some of your energy and everything rubs on to me. You
Enjoy
guys are
it.
just amazing.
Enjoy your life. Amrita, well attended, all the meetings?
You know what? The meeting is attended more by the international delegates because we sent the mailers to all the international societies also, the 20 societies that we are having, we send to them. So more of the international delegates have logged in through the portal. That is the thing. That is the best part, actually. I mean, that was the intention, that international faculty and international delegates should interact. Now, in this refractive session, both this fellow, Farhad Afesi and Gatinal, and one more person, Deep Dhaliwal, I had asked them topics. They didn't give me refractive topics. Hafezi gave keratitis, Gatinal gave IOL, and so that is why, here we have our own international speakers in this session.
Oh, nice. Thanks a lot for giving us the chance.
Yes, really.
Come on, Chitra. Come on, Rupal.
It is an opportunity, Namrata. Come on. It's an honor. It's also fun. I mean, you like to be a part of this.
How many
next conference we have is a physical one now.
I know.
Many
meeting people online.
Huh?
I really want to meet people.
Good evening, ma'am.
So much.
Manpreet, good evening.
See, this is the fourth one. Manpreet has also joined before.
Yeah, I know.
Partha ka to joining mana nahi jayega because he's not joined.
If Partha has joined, he will not even show his face.
Partha has not joined. He would
He's
have
not
asked.
joined. Somebody else has joined.
Yeah. Patient.
Dr. Tityal. Good evening, sir. That's also a proxy.
No, he connects.
No, he connects. Dr. Tityal had a program in Doordarshan. So he said that I will come, but I might join in late. Am I right, Manpreet?
Yes, ma'am. That got cancelled, so we will
Oh,
join.
so he is going to be here.
Yes, ma'am.
Where are you, at home or still in the
Home, ma'am. Home. Reached today. I reached.
I know. Otherwise, if you get stuck for this, you'll get late to get home.
Yes.
I'm at the clinic. So I'll be on my way after I talk, but I'll be listening on my phone.
But your clinic is like one home kind of atmosphere.
Hello?
Posh it is. So how are the kids?
But I like to be at home. for the meeting.
Yeah, sure.
Just a reminder, we shall be getting started in 4 minutes from now. Dr. Rupal did mention that she's going to be back by 6:20. It is.
I'm here.
Hello. Oh yes. Oh yes. Sorry. Apologies, ma'am.
How can you miss me?
Sorry. Apologies.
Dr. Tityal, good evening, sir.
Hello, Dr. Tityal.
Good evening, sir.
Very good evening to all of
You're
you.
surrounded by all girls.
How lucky I am today.
No.
Normally it doesn't happen, but I think it's one of the best days for my life, seeing both Chitra and Rupal there.
And Namrata and Manpreet.
They are always there. I don't
Vardhaman has
consider them
also
to be.
joined. Vardhaman, hi Vardhaman.
Hi ma'am. Hello sir. How are you?
Hi,
Fine,
Vardhaman.
fine.
Hello ma'am. Hello ma'am. How are you?
Good to see you, Vardhaman.
Yeah, great to see you ma'am. Great to see everybody. I think we are all longing for physical meeting. So I think the AIOS Mumbai is going to be physical. So let's hope that we can make it large.
Yes.
Yes.
હવે 15 મિનિટ માટે અહીંયા કોઈ ખોલે નહીં ને આવે નહીં ને અવાજ ઓછી ના બધાને કહી દેજો.
We shall be getting started in 3 minutes from now.
But the speakers have yet to join.
We have Dr. Rupal, who's first. Looking for the second speaker, Dr. Krishna Prasad Kudlu. He's not yet. No. I'm just checking the attendees list also. No. Professor Dr. Mahipal sir has joined in. We have the third speaker, that is Dr. Jeevanis Tityal sir with us. So maybe then we could have Dr. Tityal then going second and then wait for Dr. Krishna Prasad Kudlu.
No, Dr. Mahipal is there.
Yeah.
Dr. Mahipal is there. He's third, I think.
Yeah.
Or do you have
No,
another?
Dr. Krishna Prasad Kudlu is second, right? In the updated sheet.
Wait. Let me check.
Could be 8.
I think in the images, Kudlu is 8th, and in the schedule, Kudlu is
second.
Just wait.
Yeah.
I only went by the images. I didn't look at the list.
It's okay. It's okay. You can go back.
So whatever Dr. Chitra says is going to be final.
Yeah, whatever Chitra says is going to be final.
Why are you people pulling my leg? I came to enjoy this evening without any responsibility.
Today you don't have any responsibility. You have the responsibility to present Chitra.
Yeah, that's there.
Good evening, Ji. Good evening.
Vardhaman, you should attend a MOS meeting.
Sir, change कर लिया अपना वो. Yes, it is looking different today.
Which one, ma'am?
Why?
The one where
you're wearing a different coat today. That's why maybe used to.
You mean I have only one coat?
No.
So Harsh gives me tough competition. Right?
Good evening, Dr. Mahipal.
Good evening, Ji. Good evening.
Good evening,
Hello,
sir.
Mahipal.
Good evening, sir.
Hi. नहीं order का कुछ वही है 1 2 3. Anyway, I think we can start. If it's 6:30, no.
Yes.
6:30 we can start.
Yeah.
So we would.
Dr. Mahipal has matching. Your attire is quite matching. Today is little different.
No, it is different. No, yeah, it is nice. Not different.
No,
it is
I
really
think
very
he
nice.
has. I think he has lost a lot of weight too.
So that's good. That's very good.
I know. That's a thing which
You
makes
should gain something else and lose weight.
Apologies to interrupt, but we are about to go live. And yes, the Grover team has given us a confirmation we are live, and we would like to get started with AIOS International Refractive Surgery session. To get started, we have our chairpersons, Professor Dr. Mahipal Sachdev sir. We've also got Dr. Jeevan S. Tityal sir with us. We've got our co-chairpersons, Dr. Partha Biswas and Dr. Chitra Ramamurthy ma'am. I request the chairperson and the co-chairpersons to please take it forward from here.
Good evening. And,
Yes, sir. Yes, sir. I was about to call you only. Yes, sir.
Good evening and welcome to this new innovative concept of an international ophthalmic conclave, which is running for 3 days. And thanks to Dr. Namrata for having organized this. And this session, we'll be talking about refractive surgery. And I have Professor Jeevan Tityal, who is the chief and professor and head of refractive at RP Center and a great surgeon. Dr. Chitra is again a great refractive surgeon, and Dr. Partha, chairman scientific committee, will be joining us. So without much ado, because we have a lot of speakers and it's 8 minutes per talk. So let us go on to the first talk, and that is by Dr. Rupal. And I think, as you all know, that she's one of the leaders of refractive surgery and has pioneered a lot of FDA trials for the SMILE procedure as it is known today. She's the medical director and head for Center for Sight at Vadodara, and she'll be talking about back to surface, I think, PRK, right?
PTK Art and Science.
PTK, sorry.
Art and Science.
Dr. Rupal, please.
Thank you, Dr. Maipa, for these kind words. If you, good evening, everyone. And I would like to give a special thanks to the organizers, but a real special thanks to Dr. Namrata for organizing this. Are you able to see my screen?
Rupal, you have to open the PowerPoint. There's some Excel.
Yes. So you can see my screen, right?
Yes, ma'am. Just
okay. I'll just open the PowerPoint and make it full screen.
You have to first unshare what you're already sharing. Yeah, now it's perfect.
Now has it come?
Yeah, just go to full screen.
Yeah.
Just go to full screen.
Yes. Is it happening?
No, you come down. Yeah, that's fine. Good.
Okay. So a special thanks to Dr. Namrata. And if you all are wondering why in a refractive surgery session, we are talking about PTK, which is phototherapeutic keratectomy, let me tell you that's the best way you can utilize your excimer laser. So I'll just give you a brief on the art and science of phototherapeutic keratectomy, which is another great way of optimally utilizing your excimer laser. The objective of PTK is to remove or for the treatment of diseased corneal tissue. This can cause an improvement of best corrected visual acuity. Sometimes it's used for elevation of visual symptoms such as monocular diplopia, starburst, or glare. Sometimes it's done only for non-visual symptoms such as pain, foreign body, and other symptoms. And simply for improvement in cosmetic appearance of the eye, PTK still can be used. The rationale for PTK is that the excimer laser has the potential for removal of diseased corneal tissue. And this was recognized right from the very beginning of the ophthalmic excimer laser's career. The lamellar structure of the cornea lends itself very well to the excision of diseased superficial tissue, leaving a healthy cornea behind. And this is what really helps. Manual keratectomy is often unsatisfactory for all except the most superficial lesions because it can cause scarring and opacities on the cornea. So alternative includes lamellar or penetrating keratoplasty. But the excimer laser has very special properties. It can remove precise amount of tissue, leaving behind an absolutely smooth bed with no collateral damage to the surrounding tissue. And therefore, it can be applied with in various corneal conditions like recurrent corneal epithelial erosions, band-shaped keratopathy, corneal dystrophy, recurrent pterygium, and so on and so forth. You can compare it with lamellar keratoplasty because in all this, lamellar keratoplasty would also work that well. But the advantage of having a PTK procedure done is that it's a simpler technique. It's cheaper because you don't require this donor tissue, which is really so much scarce and in demand. And the recovery is very fast without the need for much steroids. And therefore, it does lend itself to a very advantageous position. However, the disadvantage or the limitation of this particular procedure as compared to lamellar keratoplasty is that you can treat only pathology which is limited up to 100 to 150 microns of the very superficial lesions. And the induced hyperopic shift can be quite significant. So you need to learn the procedure and the application really very well. So that was the science. The art is to know whom you should be treating and how you should be treating correctly. Our experience is mainly for corneal dystrophies, for treatment of corneal erosions and treatment of recurrent pterygium. And I would like to share an example of a corneal dystrophy. It's a patient, male age 48, with diminished vision since childhood. There is family history of progressive diminution of vision and other family members also having similar affection. The best corrected vision when we saw him was in the right eye 624 and in the left 636 with a very high astigmatism of -4 diopters. So we first attempted PTK on the left eye on 24th March of 17. And this is what it looked like on slit lamp before the surgery. 2 weeks post-op, you can't believe this is the same eye. The uncorrected vision was 624. However, the best corrected vision with plus 2.5 diopters was 6.9. So we realized that it was causing a lot of hyperopic shift. And therefore, when we did the other eye, we made compensation for that. This is the OCT comparison. The upper part shows the dystrophy in place. The lower one is after the PTK procedure. For treatment of corneal dystrophy, laser can remove tissue from the first 100 microns or so. So you have to design the laser in a way where you want to, you know the depth at which you want to go and try and remove that much. Treatment of very deep layers could lead to a massive hyperopic shift or ectasia, and therefore it is not really advisable. We remove the epithelium mechanically or with the laser, and the laser is then free scanned to remove scar tissue layer by layer. And you do need to use a technique of smoothing in order to get an exact final outcome. Now, if you scan the laser without any fluid, you'll be mimicking the same opacities which are there at a lower depth with very little benefit. So even if the opacity becomes less, you would still have not so great vision coming up because of the irregularity still persisting. That's why you need to scan with the fluid in place so that the first few shots of the laser goes only through the fluid. The next one goes through the projecting abnormalities and the fluid. And ultimately, you can come down to a layer where you are removing all the opacities along with the irregularities. And that's the endpoint that you are wishing. As regards recurrent erosions, we know the basic pathology, so I'm not going into that. What we do there is to remove all the loose epithelium, and the defective corneal bed is smoothed with laser in the shaping mode. And then you take the laser to a spot mode where you can actually control the frequency with which you can pound those laser shots. And the marginal epithelium is then pounded with these high energy density shots. This is like doing epithelial puncturing. And the eye is then pressure patched and allowed to heal, and you can have results like this. The slide to your right shows the epithelial erosion, and you can see that the area extends right beyond it and also encroaching upon the epithelium, and not just the abraded area or the eroded area. So you need to remove the epithelium in all that, smoothen or remove the defective basement membrane. And you know that once you have an excimer laser removing any membrane, you get a pseudomembrane formation, which has a much better adherence to the epithelium now. So the slide to your left shows 2 years post-op picture, and you can see that it's as smooth as a normal cornea. As regards recurrent pterygium, if the corneal bed reepithelializes very quickly after surgical excision, then it can prevent recurrence. More importantly, in recurrent pterygium, because there are different planes which have been crossed, you can leave behind a very big opacity if you don't use the excimer laser. This is one such example. The slide to your left upper part shows the pterygium. The slide to upper right shows immediately after excision. But if you just leave it at that, you can imagine how much of the corneal opacity can be left behind. So the slide to your left down is the one which is showing after excimer laser how much of the clearance you can make or smoothing of the corneal bed you can make. I'm sorry, it is inverted, but that's the slide of the same eye. And this is after the healing of the epithelium that you can see. This is 2 months post-op picture. So you can imagine you've also not just removed the pterygium and prevented recurrence, but you've also been able to give a good visual outcome to these patients. The complications that are possible is reactivation of infectious keratitis in case you are trying to remove an opacity which is caused due to infection. There can be microbial keratitis, there can be delayed reepithelialization, recurrence of the initial condition, great hyperopic shifts, stromal haze, or sometimes even a perforation if you've been too overzealous in your treatment. But if you learn the procedure very well, you would find that PTK is a very effective technique and it's very well tolerated with significant and varied clinical applications, leaving this so precious corneal tissue for the real indications that they are meant for. So even if we can reduce the need for use of these tissues by 10% by using these PTK techniques, I think it would be a great service that we would be doing. Thank you.
Thank you, Rupal. I think that was an excellent talk.
Thank you.
So I think she's highlighted very well the use of PTK, which is actually, I think in Indian circumstances, that is again an underutilized technique. We can aggressively look at doing that, and whoever has used it has got excellent results in specific conditions where it helps. I think we can, any one question or we can move on to.
Move to the next talk, sir. The next talk is by Professor Jeevan Singh Vityal on simplifying surgical techniques in SMILE.
Yeah.
Thank you, Namrata. And I'd like to wish AIOS success on this particular venture of something different where we have people from across the world sharing their knowledge to our members. I think we had a great beginning of this session where rightly pointed out the therapeutic use of examined laser. Looking to refractive surgery, I consider it's not only cosmetic surgery. It has a lot of therapeutic aspects also when we're treating patient with a refractive error, maybe a mild, moderate to severe refractive error also. And looking into the history of refractive surgeries, we know that since the beginning of refractive surgery, when lasers came up, till date, all the procedures, right from the surface ablation to examine laser, are still in practice. That means whatever surgical aspect we consider with laser surgeries, they still work very, very fine. I think since FDA approval of 2016, the small incision lenticular extraction, the entire armamentarium of refractive surgery laser base has changed, mainly because SMILE has advantage of lesser ocular surface disturbance, less dry eyes, and more importantly, it has a greater biomechanical stability than the flap-based surgeries, which may be an important decision-making point for a patient undergoing laser refractive procedure. If you see this confocal microscopy of one of our patients comparing SMILE versus the femtosecond laser, this is pre-op subbasal nerve plexus. And if you see after 6 months of surgery, SMILE has a definitely better looking nerve plexus, which directly implicates that patient would have less damage to the subbasal nerve plexus, which has a very significant relationship with the outcome subsequently in a laser refractive procedures. Apart from that, it gives a better ocular surface. More importantly, better stability of cornea in terms of biomechanical strength. Maybe that might lead less regression, less dry eyes, less inflammation, and better outcome for a long-term future also. I'm not going to go in the hardware and software of a SMILE system by Visumex. We know that surgery is an important aspect for all of us. We need to learn that, and it does have a learning curve. A few important aspects is that docking, femtosecond application to create the refractive stromal lenticule, Then manually, we have to extract this refractive lenticule after opening the cap, then delineating the anterior and posterior plane of dissection, complete dissection of lenticule, and taking out this entire procedure. This was our review article in the clinical ophthalmology regarding the various techniques people use for extraction of lenticule and dissection. People have various techniques, but it's always better to have something which gives a right orientation. If you see this diagrammatic representation, first we normally like to go anterior plane dissection. That means separating the lenticule anterior surface from the cap, and subsequently go posteriorly so that you have a two plane of dissection and you can remove easily. Difficulty arises when we don't actually appreciate the two plane dissection, and which can give so much of a surgical difficulties and some complications subsequently. Just to show a representative video here, you can see this is a centration based on a pupil centration. This is a creation of an intrastomal lenticule from periphery to center, then the side cut. Then we'll have a creation of a lenticule cap, which comes from a center to periphery. The once that is completed, the last one is a incision or a side cut here, which is normally 2 millimeter. If you see here, you have a two clear circles. This is a lenticule side cut, and this is a cap. Once we understand, then dissection becomes simpler. So if you massage out the opaque bubble, you can see the clarity of incision, and you can nicely open that and dissect the first anterior lamellar pocket, which is normally in a 2 millimeter, we open entirely. If you have a larger incision, which is 3 to 4 millimeter, people do it left side first for anterior, and as you saw here, then do a right side for the posterior. So this is what clearly indicates a little bit of a frill, which suggests that we have disturbed the lenticule edge. So I'm doing an anterior plane dissection that is separating the lenticule from the cap, and it has to be done in a very smooth manner. So once we have a nice OBL formation, application of laser correctly, the dissection is very light and very simple, and it takes very less time with experience to dissect out. Normally, I do a quadratic dissection so that flap doesn't flap into one side, which makes things difficult sometimes. So once you have complete dissection for all around, now you can see almost 360 dissection has been done with the spatula. You can use other devices also. Spatula gives a better movement, and you can in fact take out the entire lenticule without using a forceps. Use of forceps now with experience having almost less than 1%. That also decreases the forceps related complications. So this is our initial paper on a learning curve, where we realize you do have various challenges during the learning curve, but as you cross 50 eyes, the difficulties decrease from 60 to 2%, which is a significant decrease in your cases. So one of the most important things which normally we tell people is to correctly identify the anterior pocket and posterior pocket, either right or left side. And in this way, meniscus sign, which we described, gives a very nice appreciation of a two plane dissections and helps you to identify that you have definitely dissected both the sides here, or a posterior side at least. Accordingly, when you dissect out, if you are anteriorly, the clear line is behind the spatula. If you are posteriorly, you can see the entire edge is anterior to the spatula in these cases. If you have difficult dissection, you create a lot of difficulties or complications, and things can go wrong. This is one of my first challenging case of cap lenticular adhesion. You can see I'm doing an anterior dissection first to the pocket, but subsequently I'll dissect out the entire plane. In this case, you can see I'm doing a dissection, which you saw in the initial case. Now I'm struggling to find the posterior plane. So this is what happens normally. This can happen. You can see when I was doing an initial dissection, that time only I had gone posteriorly. If you see the initial frill, it gives you an indication you have gone posterior to the anterior plane. So this is a technique where you have to nudge out the flap edge, then go anterior to that and dissect out, and you can finish the surgery as effectively as routine case in such case. If you see, this is another case now where we normally now, rather going anteriorly, sometimes I go posterior dissection first also. That can also be done very effectively. So identify, lift the edge, then dissect out the entire area. So once you have a complete dissection done, like you see here, I'll go take the entire spatula, dissect out the anterior plane, which normally we do it. Here I'm doing a posterior plane dissection first. So once I take out the entire dissection here, you can see this visible ring is also indicate that you are directly posterior. In that situation, what I'll do, I'll just nudge out this frill with the same spatula, push it out, push it towards the central area, so you are now anterior. This flash gives you appearance of a bow type of pattern. You go anteriorly, then your dissection becomes very simple. In fact, if you dissect posteriorly first, your surgery can become simpler and faster sometimes also. So this is after 7 days of picture, which gives you indication that dissections simpler, lesser granules are seen in these cases. If you are doing a rexis type of procedure, then you have to do 2 areas of meniscus where you can peel from either side, and things can be easier also. Cap tear and side cut extension are very, very rare nowadays, but that can happen in the beginning, and that normally doesn't cause significant change also. Even for our cases where you require retreatment, which is going to be covered subsequently, you have a nice algorithm now, and all cases can be treated very effectively for retreatment also. So things have become simpler for us. Despite having learning curve, if you can really identify the 2 plane of dissection by various techniques, which Dr. Mahipal also going to talk about, then things become simpler. If you have a difficult dissection, you can compound your surgical problems. But despite the surgical problem, the outcome in a smile is quite effective, and patients have a very satisfactory results. Wet lab training may help, but it's always better to see the other surgeon doing surgery or see videos and look into the appropriate steps of your surgery to improve your results. Or you can go through various books. These are all 2 books on refractive surgery available through JP Brothers. People can go through them with the videos also. Thank you for your kind listening. And again, thank you, Dr. Namrata and AIOC for holding this meeting and giving this opportunity.
Thank you, sir. That was a very enlightening talk, like always. And coupled with your books and publications, it was very illuminating on the aspects of smile. I think on smile, we can take the questions when we finish the topic of smile. The next talk is going to be by Professor Mahipal Sachdev, who is the Chairman and Medical Director, Center for Side Group of Hospital, New Delhi. And he is going to be talking about innovations on smile.
Thank you very much, Namrata. And after a fantastic presentation by Dr. Tetial, I'll be talking about innovations in smile. So basically, there have been innovations in smile, which I'll be referring to. The first part has been covered to a large extent by Dr. Tetial, which is something that is very, very important for a person to learn. Addressing astigmatism is the second thing. Some complications I'll be talking about, the innovative use of circle software and the innovative use of lenticules. So this is how I'm going to divide the talk. So this is the meniscus sign, which has obviously been described by Dr. Tetial, and this is something very, very important. The white ring sign is the next sign that has been described by Dr. Susan. You can see that this is a white ring, which is seen in this particular case, by which you can make out whether you're hitting the edge or not. This is something that has been described by Dr. Gitansha, Dr. Ramamurthy, and this is known as the stop sign. So I'll just show the stop sign. So what is actually what Dr. Tetial said, like you go on to one side, in this case, it is the upper going on to the right and the lower going on to the left. But if you try to move this, you can see that there is a stoppage of the movement. So what it shows clearly is that there are 2 separate planes that you are working on. Otherwise, you won't get this resistance. So if you look at in this particular case, there is no stop sign which is there. So that means that you are only in one plane. Which is obviously going to have the problem. So you can see here that this is the first plane. And then as you go in again, and which you are thinking that you are now posterior, you go to the left, that's fine. But when you go on to the right, you see that it has broken easily. So this is an absence of stop signs. So there will be a problem later because you are only in one plane and you have to go and dissect that. Now, lack of cyclotorsion is something which is there or was there in a system that is there. So what can be done is that you do mark with a pen, which does not allow, which allows the infrared laser to go through, and you can see this is the mark, and you can align it to the lenticule. But now with the new systems that are available, whether it is the Smile new system that is there, or whether it is the new Zemer or the new Elita, that is the J&J that is there. So there is a cyclotorsion compensation that has come in. So that is something important in the innovations that have come in the lenticule extraction. Now, when you're looking at complications, again, Dr. Tityal has reported this, the use of the OCT. So you can see that this is an edge of a lenticule, which is there, as you can see here. So this is an edge of the lenticule. Again, this is a folded lenticule. So an OCT can give you a fantastic outcome as regards seeing what it is. This can also be used as an intra-op OCT, as you can see in this particular case. So this is the lenticule as we are going. So again, if you look at it, this is the entry. This is the second part. So I'll just show you. So once the edges have been created at the 2 points, you can see that this, can you see this? So this is going into the posterior plane. So this is easily shown that this is going into the posterior plane. So you are in the wrong plane that is there. So one has to actually go back in and try to dissect. And again, you can see now we have entered the anterior plane. And I'll just show you that when you go in, now you can see easily this is the anterior. So one was this is the anterior, and the earlier was the posterior. So the OCT use has been documented, and it is a good thing to actually go and see the cleavage plane. Now, this has again been described by Gitansha and Shreyas and Dr. Ramamurthy, and this is the use of triamcinolone. So if you have a retailed lenticule, as is shown here, you can use actually triamcinolone to actually see as to where exactly is the retailed lenticule part that is there. Now, this is the Circle software, which we have the use. There are two uses that we are going to talk about. So this is the Circle software. In this particular case, you can see that the side cut is not there. So you can see that the side cut, we lost the suction at this particular point, but since we had completed, so there is no way. So I am trying with a blade, doesn't happen. So what we are doing in this particular case is the use of a Circle software. So you could see that this was the previous cut, but because of the OBL, it had gone. So what is being done is that this is now being, you are separating it out, and you have created a flap, and you can take out the lenticule and use the Circle software in such a challenging situation. In this particular case, there is a time and again there is loss in a flap that is being created. So you can see this is again running through, and again the side cut of the flap doesn't come, and there is again a problem that is there to get into the side cut of a flap. So you can use the Circle software with only the side cut. So see here that this is only, sorry, this is only the side cut that is being created with the Circle software, and this is only the side cut that has been created, and you can go ahead and lift the flap. We have described the use of tailored stromal expansion with refractive lenticule for cross-linking of ultra-thin corneas. This was described way back in 2015, wherein we are taking a lenticule of the cornea and putting it onto the thin cornea. We are taking the lenticule from a donor, and we can see as to how much we want. We want 60 microns, 100 microns. So depending upon the refractive correction that we are doing in a patient, remove the epithelium. This is just the lenticule being taken out. And once the lenticule is taken out, you can actually put this lenticule, take the lenticule, it sits over the cornea. There is no warpage like in a contact lens, and it's not a fixed thickness that we have. And it is the same tissue that you are using. So the radiation would go in exactly as it would for the rest, and once the rest of the cornea. And once you have done the cross-linking, you can remove it. This has also been published in the American Journal of Ophthalmology, where we have said that this works, the lenticule, even with the intracorneal ring segments and thin corneas, and we have reported our results there. Now, when you look at further innovations of the lenticule, Philly has been described by Dr. Shri Ganesh, and that is the lenticule being used only in spherical cases for hyperopic correction, and you put this and you can get hyperopic correction. Shri Ganesh has also described the use of the lenticule for keratoconus. So you can put it and you can have a flattening of the cone, and that's what Dr. Shri Ganesh has described for the use of a lenticule. A smaller part of the lenticule has been described by Susan for correction of presbyopia. So these are a couple of innovations that have been described in the technique of SMILE. Suffice to say that there are, as things stand today, I think 3 commercially available systems apart from the Zeiss. You have the Zimmer Z8, and I think the Schwind is also commercially available. And within 1 or 2 quarters, I hope that the J&J system would also be there in the market, having gone on to the phase 3 studies of that system. So almost everyone, I don't know whether Alcon is also moving or not, but almost all the companies are moving towards the lenticular extraction, because that is least invasive, less dry eye, no flap related complications, and better biomechanical stability. And in thin corneas, you can also do SMILE extra for getting better biomechanical stability. So I would say that technology would change, is changing, and the future of refractive surgery is becoming more precise. Hyperopic corrections also we are working on, and hopefully we wouldn't need anything like Philly to get the hyperopic corrections. Thank you very much for your kind attention.
Thank you, sir. I think it was a very complete talk and so many innovations. And the best part is that from the Indian subcontinent, it was really a very innovative talk with innovations in SMILE. We have 2 more talks on SMILE, and then we can discuss the SMILE procedure and the subject. I would now invite Dr. Vardhaman Kankadia to give his talk on epithelial ingrowth management after LASIK and SMILE.
Thank you, ma'am. Yeah, Dr. Namrata, ma'am, is my slide visible?
Dr. Vardhaman, I think we all know him very well. He's Director, Asian Eye Hospital from Pune, and a very bright and a young cataract and refractive surgeon.
Thank you, ma'am. Thank you for the kind words. And again, a special thank you to Dr. Namrata, ma'am, for curating this amazing session. She's been a great inspiration for all of us and amazing leader to have in AIOS. I'm going to just give you a slight brief overview about some basics of post-LASIK and SMILE epithelial ingrowth, and probably try to discuss a couple of very unique cases and unique approaches in treating. Friends, as we all know, both post-LASIK as well as post-SMILE epithelial ingrowths are uncommon complications. They are characterized by epithelial ingrowths of stratified epithelium between either the flap and the stromal bed, which happens in LASIK, or between the cap and the stromal bed, which can happen in SMILE. This can lead to range of symptoms and signs depending on the stage at which we are encountering them. Fortunately, they are uncommon. However, they are known to progress in some scenario. And this is a wonderful classification given by Probst and Mashut, and they have given 4 different stages of epithelial ingrowth, especially post-LASIK. The first one being, it's a non-progressive, very peripheral epithelial cells, which require only observations. There is no intervention required, and they typically are known to disappear within few months. Some of them progress to the stage 2, in which we can see that there are epithelial sheet of cells, which you can very clearly demarcate. They are known to be progressive, so it is important that if they are actually more than 2 millimeters within the flap edge and progressive, you have to lift the flap, debride the epithelium from both the stromal interface, from the undersurface of the flap as well as on the surface of the stroma as well, and avoid any excessive epithelial trauma. Make sure that you align the epithelial flap back in place, and you can also take help of certain adjuvants such as mitomycin C and absolute alcohol to kill rest of the cells that you may not be able to debride. In spite of these maneuvers, some epithelial cells ingrowths are known to be intractable. They become recurrent, in which after your first intervention of debridement, they are known to recur again. Especially this is true for the epithelial ingrowths which have a epithelial fistula at the flap edge. This you can find out very easily by doing what is called as a fluorescein staining. In such cases, along with a typical debridement, use of mitomycin C, use of absolute alcohol, it is also important that we actually secure this flap edge very tightly with help of multiple 10-0 nylon sutures, and sometimes even the fibrin glow has been published along with that to use to basically reduce the chance of epithelial fistula. There has been also reports of use of PTK to kill the rest of the epithelial cells to reduce chance of fibrosis and also smoothen the stromal bed as well. However, in some cases, the epithelial ingrowth is absolutely extreme. It is known to be causing stromal melt, including the flap, and causes extreme topographic irregular astigmatism. In such cases, it is crucial that we actually go ahead and ampute the flap. So this is a case who was referred to us by a neighboring state. As you can see, this is a very, very large scale epithelial ingrowth into the interface after LASIK. The primary surgeon had done debridement 3 times. And once he had also put the sutures, but they kept coming back. So as you can see, I have lifted the flap now, and there is definitely a lot of fibrosis that is difficult to just lift up. There is a flap melt in the center, and you can see the epithelial ingrowth is as high as 400 micron in its thickness. I have removed the flap by flap amputation, then we used mitomycin C, absolute alcohol, a bit of PTK, and put the BCL in place. And you can see on the right side, this is 2 months after the flap amputation. The vision was improved from counting fingers to 6/9. Similar case, I had opportunity long back during my fellowship that had assisted. This was in 2009 with Professor Quinones. And you can see this was a similar case which we had interacted, and post flap amputation and the PTK, the vision again could be improved to 6/9. And we published this paper in European Journal of Ophthalmology. Friends, definitely with the help of femtosecond laser, the epithelial ingrowth chances have reduced very significantly because of much better fit of the flap edge to the underlying stroma. And that has also reduced the chances of further flap slippage, microstriae, as well as striae. It's not only after LASIK that you can have epithelial ingrowth. Epithelial ingrowths can also happen after SMILE, because you still have a 2 millimeter small incision, and that is also a possible conduct to have epithelial ingrowth. However, large subset of these reported cases have shown non-progressive epithelial ingrowth by both Sakente et al. As well as Everson et al. And they have published data of thousands and thousands of SMILE procedures. However, there are only 2 cases yet reported with progressive epithelial ingrowth post-SMILE, one being from France and the other one being from India. In one of the cases which was published from India, there was epithelial conduct. Therefore, they went through the small incision. They tried to debride the epithelial ingrowth. However, there was recurrence. And at that point, they put the sutures in place. Again, there was a recurrence. And at the end, they had to put a hydrogen ocular sealant. And at the end of this whole 3 times intervention, the epithelial ingrowth stopped to recur again, and the pace was managed well. This was an interesting case which we had encountered. This was a 35-year-old female patient who was referred to us. She underwent a very straightforward SMILE procedure elsewhere for spherical refractive error. In the left eye, the vision was 6/6. In the right eye, the vision had deteriorated to 6/36. You can see there is this small epithelial ingrowth, unfortunately, in the visual axis. However, when we looked at the fluorescence staining, there was no epithelial fistula. And therefore, this was like an isolated central cell nest. This was confirmed again on OCT, as you can see there. And it unfortunately caused a lot of topographic abnormality for the lady and caused vision to drop to less than 6/18. So in this case, of course, we had looked at the literature, and there was a published report of going through the small incision again. But in our case, there was no epithelial fistula. There has been report of YAG laser post LASIK, but this was again in the visual axis, so we didn't want to do that because it can cause scarring as well. So in this case, we had seen that epithelial ingrowth was isolated, no epithelial fistula as such. We just wanted to have access to actually debride the epithelial ingrowth and use mitomycin C. And as Thomas Edison says, there is always a better way to do it, and we have to find it. As Dr. Mahipal sir had just described, the Circle software is a specialized software which has been FDA approved as enhancement tool, which can convert your cap into a flap and give access to the interface. This is like a donut-shaped femtosecond laser pattern which appears with a side cut. I'll show you that in this video now. As you can see, this is the donut-shaped femtosecond laser application with a side cut. This is the epithelial ingrowth that you can see in the visual axis. I have entered from the newly cut side cuts, but I am entering in the same interface. That's the beauty of the junctional cuts, which happen with the Circle software. I'm going across the epithelial ingrowth, and I'm now going to lift the same interface so that we can have access to the epithelial ingrowth in totality. As you can see, this epithelial ingrowth could be debrided very, very gently and easily. Then we went to the undersurface of the newly formed flap. And from there as well, we removed the subset of these epithelial cells. We used mitomycin C and absolute alcohol to kill the rest of the epithelial cells and put the flap back in its place. So at the end, we could actually get wonderful results, and the vision improved to almost 6/9. This was a case that we published very recently in Journal of Refractive Surgery. There were such two similar cases that we combined from LVPI, and this is now published in print at JRS. So again, I would like to thank Dr. Namrata ma'am for the kind attention, for the kind invitation, and it's been a great learning session so far. Thank you so much, ma'am.
Thank you, Vardhaman. I think, again, that was an excellent presentation about a very difficult complication. I think epithelial ingrowth in a case of SMILE can be very tough and very difficult to manage.
Thanks.
So in this thing of SMILE, we'll be next going to the next talk. And the next talk is going to be by Dr. Ritika Sachdev. It is always a pleasure to introduce Ritika, who has the pleasure, who has the honor, who has been so fortunate to be working everywhere, right from LHMC, GNEC, RP Center, and now Center for Sight Group of Hospitals. She is currently the director of Center for Sight Group of Hospitals and would be talking to us about retreatment post-SMILE.
Thank you, ma'am, for the kind introduction and for always being an inspiration. And I'll just be sharing my screen now. I'll be talking about retreatments post-SMILE. So as we all know, SMILE has become a popular procedure, and the fact that enhancement post-SMILE cannot be done by a re-SMILE has been a matter of controversy. But I'd just like to highlight the various options that are available commercially as of now, and what we can do for patients who are undercorrected or have overcorrection or regression. Before starting, I would like to say that SMILE offers very stable results. At 10 years, there is no significant change from the 6-month result. So the stability makes the rate of enhancement much lower. In our practice, it is lower than 1%. With normogram adjustment, new models with cyclotorsion adjustment, and SMILE extra for higher powers, this rate of hitting the target is only increasing. When you are treating a patient for a residual refractive error post a refractive surgery, you must rule out certain things. First is, of course, the epithelial modeling. The epithelial remodeling contributes significantly to the regression, and a stable epithelium profile should be treated. This is a case which presented immediately post-operatively with shifting myopia and a reduced vision. As you can see, there is fluid in the interface here. As the fluid shifts, the myopic error shifts and the topography shifts. This patient had responded to steroids and hyperosmotic agents. Such a situation can happen in patients with poor endothelial functions or with a very difficult dissection. So this is a temporary problem, doesn't require permanent treatment. You just have to notice it and treat it. Also, the refractive error should obviously not be ectasia, as we all know, and though SMILE is a biomechanically safer procedure as per certain theoretical and practical considerations, ectasia can still happen, and you must rule out ectasia before treating the refractive error. Now, when we are treating the refractive error, we obviously do a workup like we do in LASIK for the epithelial map, but here the OCT becomes very important. Now, look at the OCT post-SMILE. If you look at it at 1 day, 1 month, and 1 year, the ability to see the planes and calculate the level of the planes is actually easier by a month. And at 1 year, these become hazy. So for your SMILE patients who at 1 month are showing some degree of residual power, do an OCT and map the depth of the planes, because this will allow you to retreat as per plan. As a SMILE patient has many planes that have to be considered. Of course, you have the epithelium, then you have a cap thickness and a plane of the cap, and then you have the lenticule plane. So these are the 3 planes that we are, the 2 planes and the epithelium that have to be considered when you're doing the surgical treatment. For patients who have lower degree of myopia or hyperopia, a surface ablation can be done, making the procedure continuously flapless. Because if you do a circle scan or a LASIK thin or thick flap, it does have the option of adding a flap. So SMILE somehow is marketed as a flapless procedure, and therefore some patients do not want a flap, and surface ablation is a good option for these patients. Do use mitomycin C in all cases where you're enhancing to avoid post-operative haze. And we use it for at least 30 seconds. And do note that these are lower refractive powers. And if you were doing only a primary PRK, you would not use MMC in some cases, but for retreatment, you will be using it in all cases. There are a lot of people who do a thicker cap, like Dr. Dan Reinstein does. This thick cap is almost at 140 microns. Now, when you have the cap at 140, you have enough stroma above it to create a de novo fresh flap. Remember, a femtosecond laser produces an opaque bubble layer, and gas tends to migrate in the passage that it offers least resistance. So if you're creating two planes very close to each other, these may intersect. So an 18 micron standard deviation is what is looked at. So if you have a 140 kind of a cap thickness, you can easily go in at 100. But if you are creating a cap at 120 or 110, you can't make a flap which is very thin, because then you risk epithelial breakthrough. So we make caps at 110, and hence we don't do a thin flap LASIK. But for surgeons who are making the cap at 140 or deeper, you can easily do a thin flap LASIK on top of that. When you are doing a lift here, do note that you have side cuts. So don't go lift in the area of the side cut, lift inferiorly, and use two instruments for counter traction to avoid any problem when you are reaching the dissection in the area of the side cut. This is the technique when you're reaching the side cut. Now, what we do is, because we have a cap at a depth of about 110, this is a perfect lamellar plane to create the flap from the cap. So how do we do that? The company has come up with various modules to convert this cap to a flap, A, B, C, D. The first is only a side cut. This makes a side cut, and this side cut starts intersecting with the cap. But remember, the cap dimension in terms of diameter is less than the usual flap dimension. So you actually need to increase the diameter in a lot of cases. How we do that is by creating a junctional cut, then creating a lamellar extension, and then the side cut. So you're extending the cap in terms of the diameter. The junction cut has three profiles: one that moves up to meet the cap, one which moves down, and one which moves up and down. Studies showed that the one which moves up and down has the easiest lift. Hence, this is the one that is advocated by the company and what we use. So I think Dr. Mahipal also showed that you can use this even for suction loss. This is the side cut only module, which comes in, this is the setting. So suppose you've done the cap at 120, you'll go 20 microns deeper. The diameter gets restricted by the cap diameter, right? And this will just give you the side cut only. These are the other modules. This is what we use for the circle scan. So this is the circle scan. This is the junctional cut, which will speak to the cap and connect the lamellar cut to the cap. This is the lamellar cut, which will extend the diameter. And this is the side cut. So if we have made the earlier cap at 120, see the junctional cut will go from 100 to 140. So this 20 micron variation makes sure that you're at least going to intersect it at the dimension of the cap, and you are able to extend the diameter to 8.8, which is what a flap really needs, particularly if you're correcting hyperopia and astigmatism. This is how the circle scan works. You use the PI to dock, and you've seen the junctional cut, the lamellar cut, and the side cut come in. So this is a donut shaped pattern that comes in, and you then go in and simply lift it, and you will do the excimer laser on the bed and reposit the flap. Remember that a relift of a LASIK flap comes with complications such as epithelial ingrowth, but this is a fresh cut, so those complications are not there, though of course you've converted a flapless procedure to a flap one. So but the results are very good and gratifying, and the refractive results are close to 6.6 in nearly all patients. So the downside, of course, like I said, was converting a flap-free procedure to a one with flap. So there are studies on where there is an attempt to do ReSmile, where the cap will have another lenticule created below it. So all in all, I like to end by saying that SMILE offers stable refractive results and many options for enhancement. And I've been showing this for, I think, nearly a year, but COVID still hasn't gone out of style. So in the context of COVID, this is a patient that we had taken up for SMILE. And you see here that there is a dark spot that has emerged. And this dark spot that emerges basically means that the laser pattern below this area is not adequate, and you are bound to have problems in dissection. So this has been abandoned because the dark spot is too close to the visual axis. If you're going to have trouble dissecting close to the visual axis, you'll never get an optimum outcome, and you may not even get a complete lenticule. So why did this happen? This is a case on the intralace. What has happened is that the patient is wearing a mask, and the breath, which is warm, is striking the interface and creating a condensation, which is, do note that any opacity interferes with the laser, and this opacity is interfering with the laser and causing the cold spot to happen. So all in all, COVID has taught us many things, including taping the mask of the patient. So SMILE is a new innovation, and these times are for keeping up with things that are new. So thank you for your attention.
Thank you, Ritika. Thank you for a very nice presentation. I think even the experts here, it would have been a great learning even for them, even for us. And those are difficult concepts to understand and to present. So thank you very much for your presentation. I think now we can take up the questions or discussion on SMILE procedure. So anybody would want to comment on the presentations so far? No retreatments have been done by anyone.
I think series of excellent presentations. I just joined in with Ritika. Of course, Circle software works very well, but we ourselves have been doing most of our enhancement with the PRK using the same nomograms as what we do for retreatments after a conventional LASIK or a femto-LASIK. And it seems to give reasonably good results. There's no nomogram adjustments. We use mitomycin C for 30 seconds, and in all cases, it's usually a small refractive error that needs to be treated. And there's no extra expense involved. Obviously, you can't recharge the patient if he's your own. And it seems to work equally good results. Of course, Circle is a more elegant way of doing things.
I think what Dr. Ram is saying, PRK post SMILE patients, like any second procedure on a cornea which has undergone previous treatment, I think predictability is a challenge there. If you have very small refractive error, maybe yes. And though, as Namrata talked about, I had not done a retreatment on any of my SMILE patients. I'm just, fearful of coming some patient back to me for a retreatment, because it's a really challenge for a thing. And I happened to just see one patient in last OPD. Post SMILE patient underwent in one eye PRK, and the vision is just 6/60, because the haze is so much, and the haze not only limits to the cap or this thing, it has gone beyond that to a deeper stroma also. So I can see the interface which is there, and the haze is in the both cap as well as to the stroma. I'm not sure how we are going to treat that patient subsequently. I just don't have a photograph with me of that patient, but patient is asking for some treatment. So as a cornea surgeon, I told if things doesn't improve in next few months with all these anti-inflammatory and other things, we'll have to think of doing some lamellar procedure in that patient. Any comments on that? Have you seen any post PRK haze in a SMILE patient?
No, we have not seen. And you must have used mitomycin. Maybe the patient would have defaulted on using the steroid drops in the post-operative period. That could be the only reason for the haze, because the amount of correction in these enhancements are so minuscule. So it can't be how to get. I'm surprised how a dense haze happened in the first.
It was very dense. Maybe we didn't have a papers for that patient. We're just going to ask the original surgeon if they have some papers of that. Maybe the patient had a high cylinder or something like that. I'm not sure. It was a massive haze. I've not seen in a primary PRK patient also that type of haze.
Dr. Tityal, I have had a similar experience in doing a PRK on top of a LASIK. So even on doing a PRK on a flap, at times you can have, so it depends on the residual refractive error as to how deep you are going and if you are, how much you are disturbing. The lack of use of mitomycin C is one thing. So what, from a treatment perspective, as things stand today, I think the haze will come down, but what you have to do is maybe start him on mitomycin drops, him or her on mitomycin drops, and that could have an effect. So I was also very, very wary of, actually, that's why my preferred technique is the Circle software, because it's like a new cut. It is not that we are relifting everything, it's a fresh cut. And that has also been advocated for re-LASIK by people to make a cut which is smaller than what it is. The only problem is that the company charges for that. So that is why a lot of people are going on to PRK. And because the point is that once you have done a smile for a patient and you subject the patient to poorer vision of a PRK and some discomfort, the patient really doesn't like it. But I have not had, there's only one case in which I am not as lucky as having zero retreatment, but as Ritika said, our retreatment rate has fallen dramatically, and it's below, or it's around 1%. The only thing is that sometimes if the edge where you are cutting or the cap becoming into a flap, if you get slivers, please preserve that sliver. Sometimes you get these slivers, and if you remove those slivers unknowingly, you get residual astigmatism. So that is the only thing, if the whole thing is not merging properly. So apart from that, I have never had surprises with the Circle software for enhancement.
As far as your case is concerned, Dr. Tityal, I mean, just one thought comes to my mind, is that you need to keep in mind the thickness of the original flap or cap that you created, and whether you are reaching the bed, in the sense that 50 to 55 microns is to go away in the epithelium. And if you have created a 90 or 100 micron flap, and in case, usually we don't treat more than a diopter and a half of residual error. If it's thicker and it's going on to the right through and through the cap or flap, then the chance of complications is a little higher. So in those cases, in spite of the fact that in case a large residual error is needed, maybe at the risk of a slightly greater risk of epithelial ingrowth, I would rather relift the flap or do a Circle software.
Yeah, maybe next meeting I'll update you people if I get a document from the primary surgeon, so we can discuss out that patient. These are the possibilities.
But actually, it has been reported that whenever you're retreating with a PRK, the risk of haze is much higher than primary PRK. And in fact, the effectivity of mitomycin C in reducing this haze is also lower.
Yeah,
so
that's true.
It is definitely a concern.
So just one small comment. I don't know whether the audience actually got it or not, but the last two slides which was shown by Dr. Ritika is a new complication that has been reported in Journal of Cataract and Refractive Surgery, and that is fogging. Like you have with the mask, you have fogging of your glasses. So this is fogging of the interface. So that the fog itself blocked out the laser beam, and we have reported this in Journal of Cataract and Refractive Surgery. So that is just to show a new complication that we had. So,
okay, so I think we'll move on to the next part. I would request Dr. Rajesh Sinha to call the next speaker.
Yeah, it's my pleasure to invite Dr. D. Ramamurthy, who is a doyen in the field of refractive surgery, to present on refractive surgery for hyperopia. Dr. Ramamurthy is the chairman of Eye Foundation Group of Hospitals and is a master in refractive procedures.
Thank you, Rajesh. Are my slides seen?
Yeah.
Thank you so much, Namrata and team, for this invitation to this excellent session. What I'm shifting gears and talking about refractive surgery for hyperopia. And basically, it's a less talked about subject simply because the prevalence is not so high. While myopia is about 30% of the population affected, hyperopia affects just about 3% of the Indian population. So hence it's lesser in incidence. And some basics have to be kept in mind irrespective of what modality you use for the treatment. A cycloplegic refraction with homatropine is a must. Just with the cyclopentylate is not enough. And correct the maximal acceptance with fogging. So the role of the optometrist is extremely important. And you have to make the most of the latent hyperopia manifest and try to go ahead and treat that. It's most often said that the regression is more often with hyperopia. I believe it's more because we are undercorrecting most of our hyperopes, and as age advances, more of the hyperopia becomes manifest, and that's why it's believed that regression is more common. In case you are able to correct the appropriate amounts of hyperopia, maybe the incidence of regression will be much less with laser vision correction. Initially, aiming at a slight postoperative myopia, maybe even if you overcorrect by about 0.5 diopters and the patient has 0.5 to 0.75 diopters, it's okay, because with the accommodation relaxing, the acceptance of the patient is going to improve. Age of the treatment is again 18 years or more, but it's not because the hyperopia is progressive. In myopia, it progresses simply because the eyeball enlarges. The eyeball cannot become smaller in hyperope, but it's simply because the manifest component of the hyperopia is difficult to determine in a much younger individual. And that's the reason that in the 30s or so, you get much better results than the patients in their 20s. And as patients' accommodation goes down, there's often concomitant astigmatism associated with hyperopia. That's something that needs to be dealt with. Most of the excimer laser companies says that up to about 6 diopters of hyperopia or cylinder can be dealt with. And though we often limit ourselves to about 3 diopters, large thin uniplanar flaps is what is recommended, for the simple reason that most of the ablation happens in the periphery, and we aim at a 6.5 millimeter optic zone size in these cases. A large angle kappa is often concomitant with hyperopia. That's the reason something like a contour treatment, where the treatment is centered on the visual axis rather than on the pupil center, is somewhat preferred. As we all know, ablation profile for myopia is right in the center, and in hyperopia, as I already mentioned, is most often in the periphery. When there is coexistent astigmatism, there's more of treatment in the axis of the astigmatism. And as I already mentioned, the results of laser vision correction is less predictable beyond 3 diopters. It's simply because not only because it's the undercorrection of hyperopia, because it is an indirect treatment where you are treating in the periphery and expecting the cornea to steepen in the center, and the biomechanics of this cornea, as well as the variability of tissue from one individual to another, makes the results variable. On the other hand, it's a direct treatment of a myopic cornea, because of which the flattening effect is more predeterminate. As you can see over here, this is what we do. Basically, it's pre-treatment, this is post-treatment, this is what it has been achieved, and it is a controlled ectasia, controlled steepening that has been achieved in the Center for Correcting Hyperopia. It's said that you do not leave behind cornea steeper than 49 diopters. When you go on to the algorithm, please remember, for each diopter of correction, you steepen the cornea just by about 0.6 diopters. So when you correct 3 diopters of hyperopia, you steepen the cornea just by about 2 diopters. When you make the cornea more hyperprolate than this, it's not only a poor quality of vision, because you end up having something like a nipple cone, but also it predisposes to dryness because it interferes with the flow of tears across the conjunctival sac. Phakic intraocular lenses, to my mind, has a significant role in the rehabilitation of hyperopic patients, because the predictability of visual outcomes is much better. Faster visual rehabilitation, what you get on first day postoperative is what the patient lives with till he gets a cataract. More stable refraction, less incidence of dry eye because the cornea has not been dealt with, and better visual quality because there's no induction of visual aberrations. But you need to keep in mind that unlike the myopic phakic intraocular lenses, which are plano-concave, in hyperopia it's biconvex. Usually the central thickness can be as high as 250 to 300 microns. That's the reason some recommend that you do not take up less than AC depth of 3 millimeters, but we ourselves go up to 2.8 millimeters. It's also important to look at the angle, because when you start out with an angle of 30 degrees, it diminishes by almost 10 degrees when you put in a phakic intraocular lens. So anything less than 30 degrees, maybe that's a relative contraindication. Most often, we do not have a central hole in the ICLs, in the phakic IOLs. In ICLs, none of the hyperopic lenses have it. In the IPCL, up to plus 3.5 diopter, you have a central hole. More thickness, because the central thickness are higher, That's the reason it becomes technically more challenging to create a hole. And if in a thicker optic you have a hole, then there's greater incidence of scattering and dysphotopsia. But up to 15 diopters of hyperopic correction is possible with customized phakic intraocular lenses. And presbyopic phakic intraocular lenses is another way to go, and where you are able to connect not only hyperopia, astigmatism, but also introduce a certain amount of trifocality. They are available from plus 1.5 to 3.5 diopters. And when you are using a plus 3 diopter rad, what you get is a 2.1 diopter for near and 1.2 diopters for intermediate. I'm a recent adapter to this, but I think Dr. Titial has been using it for quite some time. I do not dilate my patients preoperatively for phakic intraocular lenses, and that's a helon that flows out, and that's just the routine introduction of a phakic intraocular lens. And that's the diffractive optics of the lens, trifocal lens, which gives a fairly good correction. My initial experience has been pretty good with these lenses. Prelex is another aspect which is gaining popularity because of the accuracy of our present biometry, availability of premium intraocular lenses, excellent post-surgical visual outcome, an active lifestyle even in the 50s and later, and obviously a desire to get rid of glasses, which even we in our 60s have it. So obviously this is a typical patient for Prelex for me, a lady who is 54 in age, and you can see a significant hyperopia and presbyopic correction that can be got rid of. This is the kind of power that you deal with, and usually what you end up with these situations, whether it's a trifocal or a synergy, is a situation like this, which makes the patient extremely happy, and especially if the patient has a shallow AC depth and predisposition to angle closure glaucoma, that's something that's taken care of. In the other extreme, you have the cases with extremes of hyperopia. Even in a plus 16 diopter, I've treated even in a 28-year-old. Even though lenses up to 65 diopters can be manufactured, I believe that it's the better way to go is to put in a standard lens of about plus 40 diopters and then go ahead and implant a sulcoflex lens of what I'm presenting here. For each diopter of hyperopic correction, you need 1.5 diopters in your intraocular lens, in your sulcoflex lens. It's a 14 millimeter overall diameter lens with a 6.5 millimeter optic. And the Indian version of these lenses at a more cost-effective manner is also becoming available. Because of the vagaries of refractive biometry, irrespective of the formula that you use when you go on to extremes of refractive error, I believe debulking the maximal amount of hyperopia with the primary lens and then calculating the balance amount and doing this, that's a good way to go. You can see the post-op OCT and the post-op slit lamp photographs of this extreme hyperopic patient who has been dealt with. So obviously hyperopia, we owe it to our patients to deal with all kinds of refractive error at all ages. And LASIK, PRK, SMILE, though it's been talked about, has really not becomes stable and accepted. Extra procedure is another way to go. Phakic intraocular lenses, presbyopic phakic intraocular lenses, Prelex and piggyback lenses complete the armamentarium that we have as far as addressing hyperopia is concerned. Thank you so much.
Thank you, Dr. Ramurthy. And we all understand that hyperopia is a bigger challenge than myopia as far as refractive correction is concerned. Any question or comment from any of the panelists?
I think Ram did a wonderful job covering the entire gamut of correction of hypertropia. I agree to know, especially a higher degree of refractive error, even in a myopic, sometimes, in the age group touching around 40s, sometimes, refractive lens exchange works wonderfully well in these cases. The quality of vision they gain with the newer generation lenses are, I think, beyond imagination. But only concern would be to have a very nice, post-op follow-up these patients. In fact, all refractive patient or follow-ups should be as long as possible, like a glaucoma patient, lifelong, especially looking for a posterior pathology in the retina, periphery, and the glaucoma. These are two important areas which should be highlighted for a general ophthalmologist also. Sometimes they miss this area. And that's the only challenge, I think, doing a clear lens extraction is for a myopic, hyperopic patients. Otherwise, I think presbyopic IPCL and some of the other lenses which are going to come up. So what I've seen, because these are older patients and their serial assessment of lens in terms of density, or we do a DLI in the eye trace is a standard procedure for us. And the early induction of nucleus sclerosis is a major concern in these patients. So that has to be discussed with the patient. And I've done few lens surgeries in these patients, cataract surgeries. And patients are quite happy after that also, because the vision quality doesn't get disrupted because the cornea is normal in these cases. That's a major advantage of doing a lens-based surgery for a higher degree of refractive errors. I think Dr. Ram beautifully covered the entire area.
So you have loads of experience in this field. How often and how do you feel the difference between the IL power surprise post myopic LASIK and post hyperopic LASIK? If you have to do a surgery post LASIK.
I think they had. I don't remember, doing because my number of hyperopic LASIKs are very minimal. So I have till date I've not done a cataract surgery in those patients who had undergone hyperopic LASIK. I think there are 1 or 2 patients I've done. Definitely the outcomes are little different in those cases. As far as myopic LASIKs are concerned, the results are as good as normal cataract surgery nowadays, with a better understanding of a cornea and the IOL biometry in these cases. So there's no heartbeat change or worry in the patient undergone LASIK nowadays for cataract surgery. I think Ram can comment on the hyperopic LASIK and outcomes, cataract surgery.
Yeah, I think we have done a few, as Dr. Tityal mentioned. Our experience with hyperopia is always much less than myopia in any aspect. And but the recent Barrett formula takes care of this, and we go ahead and use the same formula in the few cases. I don't really remember the exact numbers, but works reasonably well. One thing that you need to remember is that most often when you're doing a intraocular lens after a patient was undergone a hyperopic correction, hyperopic LASIK, you get more often a hyperopic surprise. So you have to use the lowest power that's possible. If you are giving multiple readings of 24, 23, 22.5, maybe 23 would be the way to go rather than the highest power. And another important aspect which we have to remember is that please use the old-fashioned spherical lenses in these cases, because most often you are having a hyperprolate cornea, which already is having a lot of positive spherical aberration. So this is one indication for using those lenses.
Gaurav, I think, is a great expert on IOL power. So Gaurav, would you like to comment on post-LASIK hyperopic myopic powers?
I'm no expert, sir, not bigger than anybody else here, but we do tend to do more hyperopic treatments in our area as well. I mean, when I started my career with LASIK almost 20 years back, we used to get a significant number of hyperopes. They've somehow gone down now because there are certain villages and certain areas where we do tend to treat. And I remember treating even 6 or 7 diopters in the early days, like 2003 and 4. Now we obviously restrict ourselves, but as far as the IL formulas, I have operated a few of these patients, and we have used the Ascaris calculator and come pretty close. But of course, the myopic ones are definitely more, predictable, and the hyperopic, post-hyperopic LASIK is definitely something which requires a lot of care and a lot of thought behind. But the Barrett's is, I think, another. So all these put together give you a great idea, sir.
Yes, Barrett would definitely be the way to go because it takes into account all those. So many issues, right? From the
here, I wanted to chip in. I wanted to just chip in. It was a very interesting discussion on hyperopia, and this brings to my mind one girl I treated. Who kept coming to me for 3 years, and she was a +10, and AC depth was not going to allow anything, and her whole career, I mean, she was totally distraught and kept coming for a couple of years. So eventually I went ahead with explaining everything, and her father was very educated and she was herself good. We did a 5 diopters of hyperopic correction, and she is following up with me for almost 7-8 years now. Surprisingly, she's been stable and uses a correction of about 4.5-5 diopters, and she's a very satisfied patient. So this was something which is unique, because I was almost pushed into doing the surgery for her, which after explaining that you'll still be wearing glasses, she's very happy with even that halving of the +10. and I could avoid any kind of lens-based procedure or anything. She was a very young 25-year-old patient. So, I mean, that's just a one-off instance, which sometimes you can actually undercorrect and give them lighter glasses. And if they understand, you don't have to correct beyond 4 or 5 diopters and still allow them better quality life than you can otherwise.
One question to all the co-chairman, chairman, panelist, conveners. What are the factors which make you go towards lens exchange? These new trifocal lenses that are there, what age, whether there is cataract or not, what power, what would tilt the balance in favor of doing a presbyopic lens exchange, or not even a presbyopic, a lens exchange, I would say?
Lens exchange, I would consider doing it for hyperopes, especially.
Hyperopes only.
Yeah.
What degree, what, like Gaurav said, obviously chamber depths are pretty small, so you can't do an ICL and things like that. So supposing like the same patient which Gaurav is talking about, a plus 10, maybe age is 20, 30, and you can't do any other procedure, why would you not consider today lens exchange with a trifocal of today's generation?
Absolutely. We have done this in the sense that, there's no hesitation. Previously, we used to be more wary of, there's no question of clear lens extraction in cases of myopes. But as far as the hyperopia is concerned, with the controls that we have in place, I think I would go ahead and, for example, that double lens that I showed, piggyback lens, the patient actually required a plus 56 diopters. So I placed it again. The patient was just 17 years old. I placed a plus 40 diopters and subsequently placed a plus 9 diopters. He ended up with just about a 0.75 residual. And I think that's the way to go. And when you are dealing with such extremes of power, obviously you are going to be using monofocals. But when other patients, especially in the 50s, I would not hesitate to go ahead and do a presbyopic lens exchange. And now, of course, we have this DLI also, the dysfunctional lens index. Anything below 4 or 5, then the patient also is desirous of getting rid of glasses. I think it's a great way to go. And we are more confident of our results with our present day trifocals.
I think the only thing I would be very wary is that some of these patients could be nanophthalmos patients. So that I think we have to keep in mind and make sure that they don't get into a problem during the intraoperative period.
Yes, that has to be kept in mind, yeah.
Any experience of presbyond in these patients, in the low hyperopes at least?
I think we don't have Sri Ganesh today here.
No, +3 I have done, sir. +3 diopter. Presbyond I have done in patients, sir. And the results are pretty good from 6 years follow-up till +3, maximum up to 3.5 diopters. One patient I did up to 4 diopters. Results are very good. But only thing is you have to keep calling them for follow-up, just because of because of the lenticular changes, they may start getting more hyperopia.
The presbyond is in any case a monovision, right? It's one eye dominant for distance, near for the other eye for near, and then inducing spheric, both of them. And at the end of the day, I think they would develop a cataract sooner or later. So as it is, they are in the age group of 45 plus. That's why they are presbyopic. So my take is that I am tending to go towards refractive lens exchange. That is, and as Ram has said, there's the dysfunctional lens syndrome, etc., which is there, the quality, the contrast. So I am tending to push them towards a refractive lens exchange rather than go for a presbyond, though I have presbyond for a long time. But it's there, but a trifocal would be my choice today for a presbyopic patient.
I think, sir, you are absolutely right. If you look into people who are beyond 50 years, then this is quite easy in those cases. I have a lot of presbyopic patients for a workup I do for a IPCL there. So one of the important things is, apart from the DLI, we look into internal aberrations. Sometimes the cornea is quite good and internal aberration is very high. In those cases, phakic lenses or a presbyond lens are not going to work. In fact, that is going to compound their higher aberrations. So that can be another factor to decide, and patients normally agree. And these are patients, they normally have a high degree of refractive error, because those are people easy to counsel for any procedure. And there are some patients where I could not put trifocal lenses because the power is not available in those ranges. Simple monofocal lenses also improve their quality of vision.
And Dr. Tityal, it doesn't matter to you, but you just throw in that it will be reimbursed by insurance.
I might just suggest one other.
Even somebody is in 30s, I think it has helped. In a couple of patients, I do remember, even if he was in 30s, and with a lens exchange, high hyperopia, if we do lens exchange with trifocals or one I had done EDOF, and the patient is very happy. Actually, his quality of life has improved. So,
if I might just suggest, just based upon the practical experience that we have, not on any study, I think less than 30 doing a hyperopic correction for any form is a slightly dicey because much of the hyperopia is still not manifest. Between 30 to 38, 40, maybe doing a laser vision correction, especially low grades of hyperopia, 40 to 50 going on to presbyopic phakic intraocular lenses, and above 50 going ahead and doing a lens exchange may be a way to address these hyperopic eyes.
So if I may, yeah.
Yes, Deepti.
Yeah. So if I may just add, sir, I think our database of hyperopic has been quite huge. I think quite a few times we have presented, but somehow we feel the hyperopic, it's mostly the latent which is becomes a manifest. So if you are doing a proper cycloplegic refraction, actually the hyperopia does not change. In fact, the myopia changes much at a later age. But we do have a small subtle, like how Dr. Gaurav sir mentioned, a plus 10. We have done an out of a box treatment for maybe around 6-7 patients. So where we have done an extreme high hyperopia. So we use the Contour, the Alcon platform, which allows 6 diopters. So we have clubbed it with the first treatment being 6 diopters, and the second treatment we keep it ready. Like say if the patient has 8 diopters, we keep the second treatment of 2 diopters ready. As soon as we finish the first, we do it to the second. But yeah, I think this is limited to a very small subset of patients where they start off with a flat cornea. We have to aim that even after 2 treatments, you're not more than 48. And people who have smaller corneas, just to avoid the higher order aberration. But I think we have around 7-8 patients where we have done the double treatment. I think the highest we have done is easily 9.5, and it's been more than 4-5 years and it's very stable. So I think it's all about how you want to relax and get your entire latent hyperopia manifest and over treat. And we have to tell them that they require 3 to 4 months to relax the muscles. So many of them have improved even at the 3rd or 4th month. So I think with that protocol, so we are getting very good results. And yeah, as everyone discussed, I think in 20s we would really not want to do a refractive lens exchange. That would be ideal for 40-50. But in the age of 20 to 30, we are really getting very good results with even high hyperopics and super high like the double treatment, sir. So that is something.
It's going to be a very small subset getting up cornea high IQ.
Correct.
Otherwise you induce extras in these cases. Anyway.
And which is not there. Small eyes normally don't tend to have lot many flat corneas. There's the smallness of the eye which actually does. So that's an issue that what you have rightly said is that, and that should be message that we should not make the cornea steeper than 48, 49.
Okay, so we move on to the next talk, and that is by Dr. Chitra Ramamurthy, and she'll be talking on enhancement approaches in regressions.
You can see my screen?
Yeah.
A very good evening to one and all of you, and hats off to Namrata and her team for running the whole show so meticulously and such a brief notice to everybody. I have a lot to learn from her. So my due is to talk on enhancement approaches for myopic regression. So when we talk of regression, we need to realize that it's multifactorial. It could be a high refractive error. It could be a thin residual stromal bed. It could be eyes where you have erroneously used a small optic zone, a high astigmatism, older age group. If these are associated with dry eye status, some of those eyes which progress to progression of axial length and a myopic shift, and about the latent hyperopia unraveling, which has been discussed here. So then the responses are also multifactorial. Essentially, regression is all about epithelial hyperplasia and remodeling which occurs. And if there is more inflammation, there is an increased epithelial response as it could happen in a dry age status. Again, altered re-innervation patterns could trigger regression. Again, the steeper gradients which are created when you're doing high corrections, be it a myope or astigmatism or a hyperope, these again increase stromal remodeling and increase the epithelial response. And what has been seen is, especially in those thinner stromal beds, there's a forward protrusion of the posterior lamellae, and that could also cause a myopic shift, although temporarily you do try IOP lowering drugs. Again, because of the architecture of these flaps, the microferritum flaps, which were used more often earlier, against the femtoflap, it's seen that therein the regression is more. And surface ablations, regressions are again seen in higher corrections, which limits us in correcting in surface ablations, although there are some who still manage to do it with a higher dose usage of mitomycin. And when we look at the percentage of enhancement, it clearly tells us that in LASIK, there is more significant chance of regression as against SMILE, which is less than 2. Now, we also need to investigate and plan the course of management. So a very essential step is to look at a slit lamp evaluation. Are you able to define the flap edge? Do you think there's more fibrosis along the flap edge? Is the flap centered? How is the hinge looking? Is it a little low hinge? Would you really consider doing anything on the cornea in these eyes? You need to do a careful look at the topography, look at the corneal thickness, see whether there's a pachymetry progression, which should warn you that things may not be as rosy. Look at the surface regularity, whether it's an asymmetric bow tie or skewing or inferior steepening. Look at the Q value. Is the cornea already very hyperprolate or oblate when you would reconsider doing an enhancement? Again, look very carefully at the anterior and the posterior float. We need to rule out any suspicious elevation points. It also makes sense to do an abrometry. Look at the pupil size, the optic zone which has been used. Would you want to enlarge the optic zone when you're doing an enhancement, when the patient is quite disturbed by the primary vision? And these are all old cases, not now. I don't think we ever have an issue of because of the optimal laser delivery system. And of course, you need to look at whether there is a higher order aberration which is already caused and the point spread function is there. Would you go about regularizing the topography in these eyes along with treating for the regression? Epithelial maps give us a lot of information, and you can actually accurately plan what is the amount of epithelium which you're going to remove when you're doing these surface ablations. In fact, if the hyperplasia is more, it even makes sense that you do a PTK alone and look at whether how the residual refractive error is there. Would that itself suffice? It makes great sense to check or do a biometry in all these eyes with the regression to rule out an axial length elongation or a progression of myopia. And ASOCT, besides giving us information on the epithelial thickness, it also will tell you about the flap thicknesses, whether it's an irregular flap, which you're probably going to lift, whether the flap is uniform, what is the status of the flap. And again, most importantly, we need to do a dry eye evaluation and very aggressively treat the dry eye status. And therein again, you would even defer a treatment if the dry eye status is bad. So then these are the different options which have already been discussed partly, like would you do a flap lift? Would you do a flap recut? I think we hardly ever do it now. Would you do a surface ablation as a very safe option? Would you combine it with cross-linking? Is there any sense on doing a mini flap over a flap if the flap was very thick? Would you, and as Ritika so beautifully discussed about the SMILE-related enhancements, would you convert the cap to a flap? Would you do a thin flap LASIK if the cap was thick? Would you do a SMILE over SMILE? Or would you rarely do a phakic IOL? So the determinant of each procedure, like when would you do a flap lift? It makes sense that we lift the flap only if the treatment is less than 3 years. It's very important to define the flap edge and ensure that you do a smooth lift of the flap without surrounding epithelial disruption, because you do not want to seed in any epithelial nests. And it's also important that it should be a centered ablation within safety parameters. We should be very conscious that we should not lift thin flaps, buttonhole or irregular flaps with low hinges. And if the flap lift is actually considered beyond 3 years, like a lot of epithelial hyperplasia is there and you feel no point going and doing a PRK again in these eyes, it makes sense to then debride that epithelium a little beyond the flap margin all around. So that itself would ensure that there is no epithelial ingrowth. Now, supposing the original flap is decentered, it's small, then you could take a deeper cut, a little larger diameter if the corneal thickness allows. You could do a mini flap over a LASIK flap if the LASIK flap was very thick, these are more theoretical discussions. But what we also need to remember that if the plane of cut differs, there could be fragmentation, irregular astigmatism, and it's actually not a preferred option. Now, this is just to show a little decentered flap wherein a deeper flap was created and the flap was lifted and treated. Surface ablation apparently looks as a very safe option in all situations. And you could actually take a call whether you're going to do a wavefront optimized treatment or if it's a irregular topography, whether you do a topo-guided approach. And that comes as a great solution in these difficult moments. And you could actually incorporate the epithelial thickness and customize your PRK treatment. Mitomycin is absolutely necessary to address his, even more so in an enhancement case. And it could also be combined with low fluence CXL, especially in borderline CCT and hyperopic ablations. We do realize that surface ablation options have really expanded because now you could do regression, enhance in post-SMILE, post-RK, complicated primary LASIK procedures, again, always combined with mitomycin. And I think we should remember that you could expect microstriae when you're ablating on a thin flap. And even the post-op regimen, if there is a delayed epithelial healing, you might have to leave the bandage contact lens for a longer time and use more lubrications. SMILE, I feel it's a bit redundant to discuss after the way Ritika had spoke, but more for completion. We could look at enhancement like whether depending on the flap thickness, cap thickness, the stromal bed thickness, and also keep in mind whether the patient desires to remain flapless. And if the patient desires to remain flapless, PRK makes sense. And because anyway, all that we are doing in regression is treating small residual errors. Of course, a thin flap LASIK, if your original cap has been thick, is possible. And of course, doing a primary SMILE anterior or posterior. And circle software makes true sense if you are wanting to treat regression beyond PRK and of course, phakic IOLs. Again, when it comes to PRK, you could do an wavefront optimized or a topo-guided augmented with mitomycin C, especially for decentered ablations. A topo-guided really works well, but it helps to take the AIOSIC inputs. And again, unlike what Ritika said, I did go through a lot of studies. PRK and SMILE, I do not think that the inflammatory response is more, that the haze is more, but maybe she would have some sound articles. And thin flap LASIK, again, it has to be very, very sure that the cap is really thick because it could impinge on the original interface. You could actually create a vertical breakthrough because the flap is going to be very thin, and there could be bubbles which create punctures in the corneal stroma. Secondary SMILE, I have very limited experience. I do understand that Sri Ganesh has done anterior and posterior SMILE procedures, and it's not done too often. And circle software, again, has been very well shown. Like largely, we would prefer to do a D cut, although as she had said that the A cut is not creating a lamellar ring or going deeper or more superficial to the pocket. And in D cut, you go right in the same plane and create a lamellar ring, and then go ahead and do a junction cut and lift the flap. So I'm just showing how the flap gets lifted and how routine this procedure is. So essentially, when you're thinking of doing regression treatment post-SMILE, it really makes sense to do a PRK procedure, or if you want to do a circle software, a D approach would be most ideal. Phakic IOLs and regressions are essentially only if there's a large residual error, supposing there has been a progression of myopia. But otherwise, I really don't see whether a phakic IOL has a role to play because most of the residual regressions enhancements are done for small amount of regressions, unless it was a surprise and a patient has come from elsewhere, which is always the cause, because we don't create such huge problems, do we? So I would like to conclude that we have to remember that all the complications in a primary LASIK procedure has to be kept in mind. So you need to anticipate epithelial ingrowth. You have to strategize your treatment protocols. You have to ensure that haze is countered most effectively. You have to be careful that you do not miss out an ectasia. DLK has to be anticipated. There could be a rare case of infections, and increased dry eye status has to be countered most effectively. But on hindsight, we can say that well investigated regressions can definitely be well managed. Thank you.
Thank you, Chitra. I think that was a complete complete talk. I mean, there's hardly anything to discuss. You've reviewed everything and spoken everything so well. So I think we will now go to the next speaker, and that's Dr. Krishna Prasad Kudlu. Smile versus PRK versus LASIK, which one is good for the patient? So let us hear from him. We know that you do a lot of smile, Kudlu. So I have a feeling you're going to come out with, smile is best for the patient. But anyway,
thank you, Namrata madam.
But anyway,
introduction.
let's hear your talk. Dr. Kudlu needs no introduction. Medical Director of Prasad Netralaya, Super Speciality Eye Hospital, Udupi, Mangalore, Sulia, and Tirathali. And we also he's the scientific committee member of the All India Ophthalmological Society. And more importantly, we always enjoy his meetings that he does in Udupi and in Goa, etc., etc. And we look forward to it again in the coming years. Thank you so much, Guru.
Thank you, Namrata madam, for a wonderful introduction. In fact, I would love to do more and more this kind of meeting. Hopefully, I think COVID will end and soon we'll have one more beach festival as early as possible. Once again, thanks for the opportunity. I'll be talking about PRK versus LASIK versus SMILE, which is best for the patient. I think most of the things has been discussed by the previous speaker. I did not have to talk much about each procedure, but we started with the surface ablation. Later on, we went on to do a LASIK procedure, and then later on comes the customized treatment, then up come the femtolasic, then up to the SMILE. But still now, once again, most of the surgeons been now once again changing over to surface ablation. Of course, as we all know that surface ablation started way back 1990, then become little bit unpopular. But now if you can see, a lot of advancement happened in the technology of the surface ablation that makes the surgeon more and more comfortable and risk-free. So these are the few indication, real indication where we opt for surface ablation, especially in case of thin cornea. Very important, people with the larger pupils and patient with the even epithelial basement membrane disease. Even you can combine with the bioptics also. And of course, as Dr. Chitra madam said, that one of the very good treatment, especially for top-up correction for residual refractory error. So this I'm not going to talk about. There are different methods to actually take out in PRK to take out the epithelium. But I think some of us, been doing a LASIK procedure with the help of 20% dilute alcohol. The loosened epithelium will put a sidewise, then the stroma will be treated, then later on epithelium is replaced. Of course, epiLASIK, few of the machine, especially Moria, with that you can still perform this epiLASIK. I don't have much experience with this. So these are the few problems with the PRKs, I think mainly with the corneal. These are the pathophysiology behind PRKs. I am not going to discuss much about this. I think previous speaker might have already told. But very important, why people really doesn't want to do the PRK, because of the pain management. Some of the sensitive patients are really, you take out your time, keep calling you up to 48 hours, they'll have a very severe pain. Of course, my friend Rohit Shetty has been trying with the ketorolac soaked BCL. He has been putting over the PRK patient. He tells that the pain is much lesser with these patients. Of course, now I think most of us, I think everybody using this topical mitomycin after PRK, especially the thumb rule is 0.02% for 10 seconds for every diopter. If you want to do a secondary procedure, I think you have to put it for 1 minute. Of course, management of post-haze is also very, very important. I think you may have to tackle them in the steroid. Let me come to the LASIK. I think most common elective surgery procedure performed in the medicine, and probably every patient come to us, whatever the ornamental you are having, still they come with, they want to get with the name of LASIK. So there are few problems with the LASIK which has been overcome by the femtosecond LASIK. The advantages are much with the femtolasic, especially you can really plan with the better flap thickness. and lesser variation in the intraocular pressure during the surgery. Even compared to the blade LASIK, chances of dry eyes is much lesser, and even can be safely done also. Even there are few issues with the femto LASIK patient with the even come with the DLK, even OBL, even increase the duration of the treatment. So I think Relic Smile I've been doing since last 7 years. Already Professor Tithial sir already showed about his experience and how easily he can do. Basically, it's a single step procedure, flapless. So no ablation, no flap. And with the all femtosecond machine, probably Carl Zeiss Visumax. Now, couple of companies also come up with the same procedure. The advantage is basically it's a very soft, safe section. The cone is physiological, no need of changing the station, and a very soft laser. So I think all this part I am not talking, but if you, these are the few small advantage, less energy on the cornea, especially when you're treating a very high myopia. This is very important with the less induction of the spherical aberration. There's a few advantage. Some of the studies show that a higher biomechanical strength, so chances of ectasis are much lesser compared to the any of the procedure. Of course, most of us been doing this procedure. You can do the incision between 1 to 4 mm, and normally the patient get back to, if your manipulation is very less, they get back the vision immediately. But what are the issues with this? Of course, still very high astigmatism, sometimes chances of undercorrection. I think newer machine may come with the cyclotorsion compensation, but the older machine doesn't have this. Of course, we are still waiting with the hypermetropy correction that I think yet to come. So let me come to a comparison between SMILE versus LASIK versus PRK. If you think about higher order aberrations, spherical aberration, in SMILE, definitely there are a lot of studies you can see down here, significantly much lower compared to LASIK and PRK. When you think about post-surgery regression, I think you all agree. I think the post-surgery regression is much, much lesser in SMILE in comparison with either LASIK or with the PRK. Even with the PRK is okay, but if you compare with the SMILE, definitely SMILE has got advantage. Of course, if you think about dry eye, of course, PRK and SMILE will have a same score over each other. But if you think about SMILE and LASIK, I think definitely because of the lesser damage to the subbasal nerve layer, normally the chances of dry is much lesser, and even patient have a better post-op and corneal sensitivity. When you think about the corneal biomechanics, there are a lot of papers you will get in the journals, but I think some of the study really show that less biomechanical effect on the corneal integrity compared to LASIK. So this is because of the what we do. So one more thing what I want to tell here, tissue evacuation in SMILE happens to be considerably more deeper than the PRK and the LASIK. Compared to PRK, ablates always Bowman's and the anterior stroma, which is the more stronger layer of the cornea. So if you see all these comparison, I don't want to discuss few of the cases, but I think definitely most of the cases, SMILE has got a definitely better advantage than the other procedure. Once again, I thank Namrata madam and the whole team for this wonderful opportunity. Thank you one and all.
Dr. Rajesh.
Thank you, KP. It was a very nice talk, and I guess definitely SMILE, based on literature, has better scores over LASIK and PRK, but definitely LASIK has borne the brunt when we were learning refractive procedure. At that time, LASIK was there, and now we have become wiser also. So that is also one thing that has helped in getting better outcome. So thank you very much, and we will have to move on to the next talk, and the next speaker is Dr. Gaurav Luthra, and he will be talking about what have I done differently this year in refractive surgery. So that's a very unique topic, and let's listen to him what he has done differently.
Thanks, Rajesh, and thank you, Dr. Namrata, Rajesh, and the whole AIOS team for inviting me to speak here. Are my slides visible and I'm audible? Right? Thanks. So I thought I'll just put across these few things that it took me back almost 20 years when I started doing LASIK and with this pachymeter and topographer, and that used to suffice with what we were doing with PRKs and our microkeratome LASIK, and we were so happy at that time. And now, with all these gamut of equipments, it's made things life has become so complex. Yet, I think for patients, it's added a lot of value. I mean, what Rajesh just said, that we've become wiser over the years. So of course, the Pentacam, which probably still remains my most important instrument today, in spite of so many other things available to us. But I think I wouldn't manage a single day without a shine plug imaging. And I think what we, over the last few years, last 4 or 5 years, we've become more and more dependent on epithelium thickness mapping. All of the speakers have spoken about mapping, and so I won't go into any details, but it really helps us not only in evaluating our patients, but also our enhancements and the surprises that we might see, sometimes picking up eyes which are suspicious, or, enhancement eyes where you want to do a planning, especially if you're doing a surface, enhancement procedure. Or if you have refractive surprises following refractive surgery in the early periods, you can actually see the epithelium, and it can tell you so much of how to handle these patients. If there is asymmetric healing, it can give, you can give more time to the patient for how the surface is going to change over a period of time. So it's quite intriguing and really nice to have epithelium mapping available to you for every patient. Now, the other device which has really helped us over the last few years, and again, a lot of us have spoken on that, is the eye trace. So I will not go into the details of what an eye trace can do, but I thought I'll share this one case which came to us, a 25-year-old girl with one eye stable correction for about 2-3 years. Right eye showing a correction of almost -20 with a 3.5 cylinder, improving only to 636 in this eye. So it was a amblyoptic lazy kind of an eye, and the other eye was good and improving to 6.9 with a smaller correction. And we had to plan a surgery for her. She was going to get married, had significant anisometropia which she wasn't able to handle, and surprisingly the pachymetry came really small. And since she had a stable refraction for a few years and was keen for a refractive surgery, we had to find an answer. The AC depth was adequate for any kind of phakic lens implant. The epitheliums looked fine. Now here comes what we are all talking about. The left eye showed a DLI of 10, and that was quite good for undergoing any kind of a procedure. And the fellow eye showed just about a 1.21. Now this was the right eye which had the -20, and you can see that the also showing that potential visual complaints in the right eye with all the blur and the night myopia, whereas the left looks pretty good. So we had to take a decision, and this you can see here that the internal aberrations are very high in the right eye, and we decided to go for a clear lens extraction in the right eye and for an ICL in the left eye. And post-op, right eye has a DLI of 10. So you can see she improved to 6.9. It was remarkable for the right eye because the patient was so happy. She was almost comparable vision in both eyes. And this was one big example of how technology can, help us in making better decisions. So this is only one way how the eye trace has helped us, but I think for every patient, it gives me more and more information, and it helps you make these decisions much better. Now, here's another patient who was having a small refractive error, was seen by us for potential refractive surgery. And she had this inferior steepening. Otherwise, the maps were pretty good. And the Weberian Ambrosio maps looked fine, but they were borderline there. And epithelium thickness looked fairly good. Now, because of one, yellow flag, as you might want to call it, inferior steepening in one eye, which was not even significant, we thought a small correction, decided to go with a surface ablation procedure for this patient. So treatment plan was this. Here I wanted to bring in something that we've been really enjoying over the last couple of years is the Trans-PRK with the Streamlight platform on the Excimer EX500. So I think here what's most important to have is a good epithelium thickness map, because you can be surprised that a 480 cornea can sometimes have a 55 microns epithelium thickness, and sometimes a 600 cornea will have only about a 50 micron thickness. So you can't go by a thumb rule. And I think Streamlight results have been dramatically better. We've also been using ketorolac soaked contact lens, as Dr. Kudlu said. We've done studies for about 3 years, and we've also done the initial studies for the new product which comes from Entod. So planning, of course, I think all of us who are using this platform will be aware you can feed in the epithelium thickness over here. The only problem is that you can only feed it in gaps of 5 microns, whereas I think on the Schwinn platform, you can do it in steps of 1, 2, 3, 4 microns as well. And this works really well. I don't think a video is needed here to show how it happens, but once you've done the ablation and removed the epithelium and in one go done the ablation as well, you can use this contact lens. Now, this is something which I really find interesting, and it has really changed life. So I was sold to Smile for last 5 years that I've been doing it. But my patients post-op PRK now are no different from my Smile or LASIK patients as far as their pain is concerned. They look equally good. This patient was operated just 12 hours before the previous night, and reads, you can't make out no lid edema, no kind of congestion. She can read almost 6.6 on the chart, and very happy patients, almost no significant pain at all. So it's transformed our PRK practice over the last few years. Going on, I think what I'm really enjoying now is Contura treatments for those select patients where Contura is indicated. And, although a predominant surgery for me is Smile, but there are patients where Contura works really well, especially those with high astigmatism and with higher corneal aberrations. And again, now Contura we had been doing for almost 5 years, but what has transformed in the last 1 year is during the lockdown, we started using the Forcides software. And that has really, really transformed how we do our Contura planning and made our results amazing. I just wanted to share with you this one patient where we did a Contura treatment. This is how the screen looks like. So if you look here, this is the refractive error on top. So this is the manifest refraction. And then of course, the topolizer measured refraction here. So mostly it is a cylinder which it will pick up. So you can see here, the axes are a little off. And then you have the pentacam anterior, the topography anterior measurements and the topography posterior measurements. And once you put all this data into the machine, you get the final recommended treatment from Forcides. And you can see here that this gives you a very, very good. So I have become so reliant on the Forcides software today that I feel that it has, without this, again, I would feel disabled trying to do Contura treatments. It gives you the talus and the other vectors for the surgery. Of course, sometimes it will tell you not to proceed, or it will not calculate some of the eyes, and then you have to kind of go with a fine customized aspheric treatment or something similar. So this is the fellow eye. I will not go into the details because it requires a whole period. So essentially, I think our Contura results have been tremendous. Forcides has transformed our practice, and our quality data capture, I think, is the key to decide for these surgeries. Coming on to last, I'm not seeing the timer. Rajesh, if you'll tell me how much time I have left, maybe a minute or two, I'll just finish off. I don't see the timer on my screen. That's why I'm asking you. I'm sorry.
It's 25
but I'll try
seconds.
to finish. Okay, so in a minute, I'll finish. Okay. So this is another case, a 28-year-old male who came to us and stable refraction, correction of about -4 and -5 with a small cylinder, and slightly suspect cornea with the superior steepening, and bad maps were suspicious and looking for a surgery. Now, these are the cases where you'll have to take a decision. And in this context, I would like to mention about this study which came out from Sri Ganesh's group about their risk of ectasia with Smile. Now, this patient was looking for a Smile procedure. We were going to refuse surgery to him. However, we've been doing about last 2 years a significant number of Smile extras, and I think Ritika and everybody else has spoken on that as well. These are the corneas, borderline corneas, which will do extremely well. And I think we've had great results with Smile Extra, very predictable. We are following the protocol of 60 seconds of riboflavin with 90 seconds ablation on the 30 milliwatt platform. I won't show you the video. I think it's self-explanatory, but it has again been a big tool for us to add to our armamentarium of procedures. I think I will not discuss here. So to summarize, refractive surgery has come a long way since we started. I'm saying 30 years, but probably it's 50, 60 years. But in the last 30 years, there's been a transformation ever since the excimer laser came about. And we have a gamut of devices which give us a lot more information today. And our understanding of the finer points in refractive surgery has grown so much. And a choice of procedures is now available for the surgeons and the patients, allowing excellent visual results and safety. And since each patient is different and should receive customized advice from us, I think it's very, very important that one size cannot fit all. And these are very exciting times for refractive surgeons. Thank you.
Thank you, Gaurav, for summing it up, and for getting all the the new things which have come up on your presentation. I just want to know, Forcides as such is an off-label use as far as the Alcon is concerned. Have you compared your retrospective cases which you did on Contura with the Forcides software?
Oh, so, we were doing the, Contura based on the Alcon nomograms for almost 2-3 years. And somehow, we ended up so many times being uncertain about what we were going to do, and, always having these issues with this thing. Then we also tried out another software which was available for planning. And ever since we are on Forsities, I think things have fallen in place so completely. I've not done any formal study, but we get great results now, and they all seem to kind of fit in really, really well. So I don't have scientific data to back this up, but offhand I can just tell you that we've done, say, about 80 or 90 patients on Forsities in the last year or so, and they've been a breeze, and our post-op outcomes are great. We are very happy with how the planning is coming out.
We have also been, we have done 4 cities, but even with the regular contour treatment, the results are truly amazing. Like whenever there's a high astigmatism there, although our results with SMILE are so good, whenever the astigmatism is high over 3 and all, we just go and do a femtocontura and they do so brilliantly well.
And here I'd like to add that sometimes when you cannot do a contour treatment, I think doing a FCAT becomes really nice, because on the Vario you can actually do the capture and you can have cyclotorsion control as well. So when not being able to do a contour, if a patient is looking for a contour, and you can switch to the FCAT, especially like mixed astigmatism or other things, it becomes really nice as well.
Gaurav, are you doing epicontura or the LASIK contour?
I'm doing both, sir. Because although on TransPRK it doesn't allow us to do it in one go because you have to feed the data separately. We have done a few epiconturas as well, but most of our volume would be femtoconturas.
Okay.
Okay, thank you, Gaurav. And now it is my pleasure to invite Professor Rajesh Sinha, who's professor at Cornea Cataract and Refractive Surgery Services, RP Center, AIIMS, New Delhi, and also the treasurer of All India Ophthalmological talk on corneal cross-linking in thin corneas.
Okay, thank you, ma'am. And I'll be presenting on corneal cross-linking in thin corneas. By thin cornea in CXL means that if the corneal thickness is less than 400 microns without epithelium. So the reason is this, that if it's less than 400 microns, there is risk of UV toxicity to endothelium, and that's why there are efforts to increase the distance of endothelium from the UV rays which are focused on the corneal surface. And there are various methods that have been described in literature and that we very often use also. And the one that majority of the people use is the use of hypoosmolar riboflavin, which was described long back, I think in 2009 by Farhad Hafezi, wherein 0.1% riboflavin is used, it is constituted in 0.9% saline instead of dextran. And although the results are not at par with the conventional one, but in a thin cornea, it works well. So there are a couple of studies which have shown that the results of hypoosmolar riboflavin are reasonable, but not as good as conventional cross-linking. And but of course the safety is there, and if the corneal thickness is 330 microns or more, then you can go ahead and do a hypoosmolar riboflavin, hypoosmolar CXL. Then came contact lens CXL, the CSCXL, which was described by Susan Jacob and group, and they used pre-soaked soft contact lens over the cornea after putting riboflavin. And that was a way to separate increase the distance of the UV rays from the endothelium. And they found it was quite safe, but the efficacy has some, question mark on it, because there are 2-3 things. One is that you have a contact lens over the cornea. And there's a precorneal film, which affects the UV irradiance. So that is one issue. The second issue is that there is decreased oxygen diffusion through the contact lens. And of course, the third issue is that the CXL works mainly in the anterior 2/3 of cornea, and part of it is being occupied by contact lens, which will be discarded. So that is one issue. So these are the 3 issues which have shown that which have resulted in definite documentation that it has decreased efficacy in terms of conventional, in comparison to conventional cross-linking. Now, as far as the precorneal film is concerned, that was taken care of by use of refractive stromal lenticule, the SMILE lenticule, reported by Dr. Mahipal Sachdev and group. And in that, a smile lenticule was used to place on the corneal surface after debriding the epithelium and putting riboflavin. And the advantage was this, that there was no precorneal film. So the UV irradiance factor was taken care of, and they showed good results in the 3 cases that they reported in the year 2015. But then again, there are issues that, as contact like this, CXL works mainly in anterior two-third of cornea. So part of it is being discarded. So that is one issue, but definitely it is an option for a thin cornea wherein you can't do any other procedure. Then people have also used transepithelial CXL in these cases to maintain the epithelium, or they have customized removal of epithelium. They have kept the epithelium in certain areas, in the area which is thin. But again, they have shown that the results are not as good as conventional cross-linking. And nowadays, people less often do epi-on cross-linking in corneas. Then the idea of increasing the stromal thickness from the work of Dr. Sriganesh et al. That was Philly, which he reported. Based on that, we just thought of using a hyperopic lenticule, which was implanted intrastomally in a pocket. So we started this study at RP Center, and in eyes which were thinner than 400 microns, we created an intrastomal pocket with femtosecond laser, and then negative meniscus lenticule implantation was done. So this is how it was done. So with the help of femtosecond laser, a pocket was created. And after creating the pocket, it was dissected. And then riboflavin was injected into the pocket and kept for a couple of minutes. And then donor tissue, corneal tissue, was used to fashion a 200 micron stromal lenticule, which was again soaked in riboflavin. And then it was introduced into the pocket. So this is how it is done. And once it is introduced, it is spread well all over. And then it is checked that there's no fold in the lenticule, and then of course you do cross-linking. Now we have on day 1, as you can see here, because of inflammation, the lenticule thickness is high, but at 6 months follow-up, you can see the thickness of the lenticule has reduced down to 98 in the center and 135 in the periphery, as we had taken a hyperopic lenticule. So this was the thickness that we could see. And as you can see here, a thin cornea now has become 498. So increased tectonic strength, increased thickness, and also you can see the issue of interface haze can be taken care of by use of more frequent topical steroids. We have seen interface haze in a few cases. And what we noticed was in these cases, the donor tissue that was used was of higher age, and plus the steroid was stopped earlier. So we now use steroid for a longer period. And this is a post-op 6 months picture. You can see there's hardly any interface haze. There's hardly any interface haze in this case also. And in earlier cases, we were using 7 millimeter lenticule. Now, as we started evaluating these cases, we found out that in larger cones, what we used to see was that in the mid-peripheral part, there was lifting of the tissue. So we started using a larger lenticule. As you can see here in this case, a larger lenticule provides a better outcome. Now you can see a pre-op picture in this case. In this particular case, we have used a 8.5 millimeter lenticule. Now you can see the pre-op K1 and K2 is 53.9 and 59.2, and Kmax was 65.4. And now after the procedure, the cylinder has reduced significantly. It is 54.3 and 55. And the Kmax is 59.1. So it is quite a significant improvement. However, it is, I would say it is still in an early stage. We have to optimize it, we have to customize it, and we have to standardize it only. And then we can, actually say that this is an answer to, cross-linking, answer for, thin corneas, wherein we would like to do cross-linking. Now, a very interesting and amazing study has come up from Farhad Hafizi's group only, that is regarding adaptive fluence. And they considered modifying the duration of irradiance in eyes with thin corneas. So they kept the irradiance at 3 milliwatt per centimeter square, and the treatment time was modified. This is the study which was published in American Journal, and they found out that there was no significant change in CDVA and sphere and cylinder from baseline to 12-month post-op. Mean Kmax value reduced from 58.5 to 56.4. So there was a flattening of Kmax by 2 diopters. And so based on that, they recommended that sub 400 individualized Fluence CXL protocol standardizes treatment in ultra-thin corneas and halted keratoconus progression with a success rate of 90% at 12 months. They said that sub 400 protocol allows for treatment of corneas as thin as 214 microns, and their protocol changes time for irradiance. And for a cornea, which is 214 microns, they have used 1 minute, 30 seconds irradiance only. Now, they have reported that no eye showed signs of endothelial decompensation, but they have not assessed the endothelium. They just took the endothelial corneal decompensation as an indicator of non-damage or no effect in endothelium. So these are a few fallacies in this study, and it raises questions, more questions than giving answers for these thin corneas, because what we have always considered as a cornea which is lesser than 400 microns, if we put UV rays on the surface, it may damage the endothelium, and there are a few case reports also related to that. But they say that in a short time you can manage even in 214 microns cornea, you can do a cross-linking. Then again, no endothelial, they haven't done any specular microscopy, but they have just taken corneal decompensation as an indicator. So there are various questions. There are a couple of more questions, which of course can be discussed in a different forum when there will be time. But the point is that this is definitely an amazing article, I would say. Not sure whether we can absolutely rely at this point of time, because the concept, it changes the concept in terms of efficacy and safety of cross-linking in thin corneas. So in conclusion, I would just like to say that the aim of CXL is not only to increase tectonic strength of the cornea, it can provide some degree of flattening as well in a good percentage of cases. It delays keratoplasty, and it also allows you to have a good contact lens fitting for visual rehabilitation, as it reduces astigmatism. And we found out that with this intrastomal lenticule and CXL, all these factors were taken care of. But then the only factor that I'm still working on is the interface haze, in which a few cases have shown interface haze, a few have absolutely clear corneas. As I have enlarged the lenticule size from 7 to 8.5, things are slightly better, definitely. I guess maybe with time, all these things will, be more standardized, and we will have better answer. Adaptive fluence, as described just on the recent article, is probably effective as shown in their study. They have used 35 eyes, and they have shown that about 30 eyes have shown good results, stabilization of cone for 1 year. But of course, we can debate a lot on this article. So thank you very much for your patient listening, and I'll be, happy if
Thank you, Rajesh, for that excellent presentation, I think, and excellent insights into how to manage thin corneas, which will always remain a challenge, given the fact that there are so many treatment modalities available, and given the fact that none is really well established. So I think it was a very nice presentation.
Thank you.
Anybody would want to give any comments before we?
Very nice presentation, Rajesh.
Thank you.
Excellent.
Thank you.
So we come to the next presentation, optimizing outcomes in Feki to be given by our very young and bright and very meritorious consultant at RP Center, Assistant Professor Dr. Manpreet Kaur in Cornea, Cataract and Refractive Surgery Services. And to her credit, at this very young age, she has a large number of publications and awards and books. So over to you, Manpreet.
Thank you so much, ma'am, for the kind words. I'll be speaking on optimizing outcomes with fake trials. There are no relevant financial disclosures, and I thank AIOS and Namrata ma'am for the opportunity. And so optimal outcomes, as we all know, depend on vaulting. It's the most important determinant of having good post-operative visual as well as anatomical outcomes. So it depends on there are three aspects: preoperative assessment, which is important for proper sizing; intraoperative optical coherence tomography guided surgery, which helps to assess vault on table and also on table decision making; and postoperative assessment of the vault using slit lamp or anterior segment optical coherence tomography. So the parameters that are important preoperatively are the white to white diameter and the aqueous depth from endothelium to anterior lens capsule, which are the most important to determine the phakic size. So we have cutoffs based on the model you use. In addition, angle anatomy, open angles are required with iridocorneal angle aperture of at least 30 degrees and an adequate endothelial cell count. So what we have observed is that optical coherence tomography is a useful tool for preoperative assessment in determining the sizing. So conventionally, white to white has been used to determine which size of phakic to implant, and now we are moving on to sulcus diameter and angle to angle. Which is most accurate does remain to be seen even now. White to white has a poor correlation with the actual sulcus to sulcus diameter and results in oversizing and undersizing in quite a few cases. And sulcus to sulcus diameter has been shown to have high interobserver variance. It needs a skilled operator because high frequency ultrasound biomicroscopy is used to determine, and it has low repeatability. And in fact, image selection, unclear visualization of the sulcus, irregularities in the sulcus, misdirection of scanning can all be potential sources of errors. Then we move on to the angle to angle distance, which is measured using optical coherence tomography. And what has been observed is that it has a significantly higher reproducibility than the white to white measurement and correlates with the post-operative vault as well. So swept source optical coherence tomography is being used for determining ICL size based on the angle to angle distance, and automatic analysis is used to calculate the anterior segment parameters, and distance between the scleral spur and crystalline lens size has a significant correlation with vault. CASIA gives a 360-degree reconstruction of the anterior segment and is a useful tool to determine ICL size. It's based on the swept source OCT principle. Coming to intraoperative usage of optical coherence tomography, what we have observed is that IOCT is very useful in anterior segment surgeries. In fact, it enables real-time visualization of ocular structures, enhances our understanding of the intraop dynamics, and aids in decision-making during various anterior segment surgeries. In phakic surgeries, it helps in the assessment of vault, the orientation of the phakic and the real-time surgical dynamics. As I said, vault is adequate vault is the essential prerequisite for optimal outcomes, and an ideal vault is roughly equivalent to the central corneal thickness. So what Zeng et al. Observed was that in their large series of 616 eyes, 2.6% cases needed a phakic exchange. Of these, 50% had too low a vault and 50% had too high a vault. So all of the cases of exchange were related to inadequate vault. We performed a real-time assessment of intraoperative vaulting in implantable columnar lens and correlated it with the post-operative vaulting using intraop OCT. What we saw was that the intraop vault on table correlates well with the post-operative final vault. It's a potential tool for decision-making in extremes of vault and also helps observe real-time surgical dynamics in interaction between the instrument and the intraocular structures. So how do you measure the vault on table? We devised a scale to measure, and what the principle is that the depth of acquisition of this OCT that was used, Rescan 700, the previous version, is 2000 micron, and the height of the screen is 265 millimeters. So that is equivalent to 2000 microns. So we came up with a conversion factor of 7.5, in which you multiply whatever you get in millimeter with 7.5 and you get the actual vault in microns on table. And this is one of the cases in which viscoelastic is being aspirated after putting the ICL, and you can assess the vault on table. And you have to, the central hole acts as a correlation, as a landmark that you are in the center, measuring the central vault. And using this correlation only, I could assess that the vault on table was 383 microns, 85. Yeah, so now the newer version of Rescan 700 has an on-screen scale of 1 millimeter or 1000 microns. It has 5 boxes, each corresponds to 200 microns. So this can directly be used to assess the vault. You can measure this one small box in millimeters, and it corresponds to 200 micron, and use a unitary conversion system to get the on-table vault. So what we observed was that 18.2% of cases required an ICL explant in our series for vault-related complications. So this is a significant decrease compared to the study by Zeng et al., in which 100% of the cases required an explant for vault-related complications. So there is an enhanced safety with the newer models as well as newer investigative modalities, both preoperative and intraoperative. So what happens when you insert a phakic in the reverse orientation? So this is one case in which implantable phakic contact lens or IPCL was inserted, and it was inverse, as you can see on the intraop OCT. So it helps in on-table detection. These lenses are more flexible than the ICLs, and sometimes it's difficult to assess the orientation in the absence of IOCT. And as you can see, there is a central contact. So a decision was taken to explant the phakic on table. It was reloaded and then re-implanted in the correct orientation. Had we left it, we would have had a higher incidence of cataract, and a secondary intervention would have required. IOCT helps us detect it on table and correct it without the requirement for a secondary intervention, and minimizing maybe potentially more dangerous complications. So intraoperative OCT allows in vivo cross-sectional imaging of the anterior segment. There's a real-time dynamic visualization of the entire procedure from the initial incision to final wound rehydration. Relationship between the ICL and crystalline lens can be seen, and inadvertent touch of instruments to the central optical zone of the ICL can be avoided. Limitation, as of now, the metallic instruments are not really compatible with the OCT image capture, and there is a shadowing effect, and it's not possible to accurately assess the contact of ICL to the peripheral lens or peripheral iris while positioning the haptics beneath the iris. As you can see, when you're observing the dynamic maneuvers, and there is this shadowing caused due to the instrument. So even though there is an indentation in the center, beneath the cannula, you cannot really see if the lens is touching the crystalline lens, the phakic lens is touching the crystalline lens or not, because there is a shadowing effect due to the metallic instrument. So this remains one of the fallacies. And again, a lot of motion when it's there, it may be difficult to accurately assess. Coming to the post-operative complications, optical coherence tomography helps to assess incorrect orientation of the phakic IOL, and the complications can be prevented if you catch them in time, such as cataract, secondary glaucoma, corneal decompensation. Anterior subcapsular cataract with a very shallow vault can be observed in this case, and it's an indication for explant and phacoemulsification in this case. Extremely high vault of 1.35 mm was observed in this case with angle closure glaucoma. So when you see a iridotrabecular contact on ASOCT or occludable angles with raised IOP, you can take a decision to exchange the phakic IOL with one size smaller. So optimizing outcomes with phakic IOLs is determinant on the correct sizing. It is imperative to achieve an adequate vault. Intraop OCT and both even pre-op and post-op ASOCT help enhance the safety and predictability of surgical outcomes. Right from vault, the intraop vault correlates well with the post-op vault. Decision-making, extremes of vault, you can take a decision to explant or rotate the phakic IOL in non-toric cases, and in inverse phakic IOL, on-table detection and management can be performed by explanting it. And real-time phakic IOL crystalline lens relation can be observed, and this can help prevent lens touch. Thank you so much. I would like to acknowledge Professor Jeevan S. Vityal, who's my mentor and guide, and also thank AIOS and Namrata ma'am for the platform. Thank you.
Thank you, Manpreet. I think that was an excellent presentation and excellent work that has been done, especially titrating and calibrating the intra-op OCT. Now they've given a scale even before that scale was not available. Professor Tityal, sir, would you like to say something?
No, I think all the required inputs were there as far as faking error is concerned. This is one area I think people are going to venture not only for a higher degree of refractive error. I think even for a moderate to low degree of refractive error, people are going to go into faking IOLs, especially now coming out with the press biopic range, which may be or diffractive trifocal designs or a sort of extended range or lenses. I think future is there for these, and people have to learn various techniques. And most importantly, I think the sizing has to be more appropriately calculated, because sometimes you don't get the appropriate sizing because you have a limited sizing available from these designs. But luckily, it all gives you a reasonably good post-op vaulting, because the range is quite huge, 250 to 750 microns. The most lenses fit into all these parameters. But I think what we have seen in these cases of faking IOLs, if done properly, the results are fantastic, and complications on table or subsequently post-op is very rare. She talked about some of the cases where we had to do explantation, and most of these cases were of older designed ICLs, and they were all referred to us from a different areas. I think newer generation lenses are almost free of complication because of sizing can be done better, and surgery is much better understood by these cases. Especially now, people use hydroimplantation. The viscoelastic totally gone off. The type of methyl cellulose people used to have, that used to create the sort of a layer underneath the these phakic IOLs over the lens surface, and they never used to go off. And those are the causes for a lenticular opacities happening subsequently, and inflammation also. I think last one of the talk I heard, we talked about Urich-Javalia syndrome in phakic IOLs, and those are mainly because of a high IOP and inflammation in these cases. So those are rarity for these cases. I think future is apart from Kudlu and talked about phakic lenses over the PRK cases. So PRK is also coming up, and maybe phakic I will take over subsequently for all types of refractive in future. So looking the reversibility of an entire procedure.
Can I make a comment? Namrata?
Sure.
Yeah, sure, Dr. Ram.
A very interesting application of AIOSIC in phakic intraocular lenses. I haven't seen this before. But okay, when it was reversed, you went ahead and exchanged reloaded the lens and put it back. But have you ever noted a very low vault or a very high vault and then change the sizing of the lens on table? Because obviously you would not have different sizes available to you at the same time. Another thing is, I think another fallacy would be that judging on table would be, if it's an ICL as it's currently available in distilled water, the size of the lens that you implant does not change. But as in the older lenses, ICLs, when they were earlier dispensed in saline, and currently some of the Indian lenses which are dispensed in saline, the actual size of the lens appears 1 to 2 days after the implantation. The initial size is somewhat smaller than the final size the lens takes on. And that's the reason even the power changes. Earlier, they used to be labeled as -23, but effective correction was just about 18 to 18.5 diopters. So maybe this application of judging on table with the AIOSIC might be okay with the current form of ICLs, but may not be applicable to some other phakic intraocular lenses that we are using. And Tityal commented about hydroimplantation. Another very effective implantation which gives you enough space also is you can use heel-on, which was essentially contraindicated earlier. And what I find is that once I do it with Helon, just the process of hydrating the incisions makes the entire Helon flow out as a bolus. So you have enough space available to do a gentle implantation. At the same time, the vagaries of what irrigating the entire methyl cellulose out is not there. And the final comment is about the sizing of these lenses. The thought that, it's the sulcus where the lens sits, so measuring the sulcus would be a great idea was thought about. But then measuring the sulcus has always been a challenge. And ASOCT again, which measures the angle, may not exactly correlate with this sulcus sizing. Most of the phakic intraocular lenses manufacturers size their lenses based upon the white to white diameter. So maybe as of now, that would be the better way to go for most practitioners.
Yes, sir. Regarding on-table explant for two extremes of vault, I think we haven't performed any. Unless we observe a touch, we will not perform an explant. And regarding the other extreme, too high a vault, we'd rather observe to see if it settles down with time. And in some, we have rotated the non-toric phakic IOLs 90 degree, and we have observed that the vault has settled down. And the second comment, Helon, we are also routinely using Helon for injecting the phakic IOL, not methyl cellulose to fill the AC. And the third one, yes, I do agree that white to white, as of now, that's what we are using, even though angle to angle and sulcus to sulcus do sound very exciting. And maybe sometime in the future, we'll have more automated measurements. But as of now, even we do rely on white to white and digital calipers. And we, rather than relying on one method alone, we take a combination of 2-3 readings to see that there is repeatability.
Right.
Excellent. I think Rajesh, can you call the next speaker? I think.
Amrita, we're waiting for a dinner to reach to our
Yes,
home.
yes. I think.
भेज रहे हो क्या dinner हमारे लिए?
Yeah, अभी नहीं भेज रहे, कल भेजेंगे sir. Rajesh, can you?
Okay, so
Chitra
we have now Dr.
Chitra
Sujata
Namta should
Mohan.
make sure next time you supply dinner to our house. Sorry, please go on.
So we have Dr. Sujata Mohan who will be talking about management of flap stria.
Okay, thank you, Dr. Namrata, for giving me this opportunity. It's really a wonderful session we've had so far, and I'm very happy to be part of this iconic list of speakers. Escape items. I don't know how to get out of this 1 minute. Yeah. Can you see my screen now?
No.
No?
We can't.
Okay, 1 minute. Let's share screen first. Okay. Yeah.
Yes, we can.
Yeah, okay, thank you. So this is actually a video which is running for 7.5 minutes. So we'll be done in no time. So the authors have no financial interest in any of the products mentioned in this video. Flap striae are defined as small wrinkles or fold in the cornea as a result of LASIK surgery. The most common classification of flap striae divides them broadly based on their size. Microstriae are microscopic superficial wrinkles that are generally asymptomatic and often only detectable on microscopic examination of the cornea. However, macrostriae are larger and full thickness folds that usually cause noticeable visual impairment. The incidence of clinically significant striae requiring treatment is between 0.2 to 1.5%. The common causes of striae are thinner flaps, higher ablation depth, misalignment of flap after replacement, flap contraction and desiccation during ablation, flap wrinkling during stretching, movement of the flap on the first post-op day, tenting of corneal flap over an ablated stromal bed, a nasal versus a superior hinge, and excessive manipulation of the flap. Micro or macro striae not causing visual symptoms can be left alone. Flap folds such as this can cause severe visual symptoms and have to be dealt with immediately. Visual symptoms linked to striae include
irregular astigmatism, optical aberrations, monocular diplopia, and degraded uncorrected visual acuity and best corrected visual acuity. Early intervention is recommended in these cases. In the first case, the pupil is dilated for a good transillumination effect on the striae. The flap margins are identified. The Sinskey hook is used to break the epithelium. The flap is lifted and floated on the bed. Two dry merosal sponges are used to stretch the striae perpendicular to its direction. The stretching is done repeatedly till the visual axis is clear. Flap is replaced meticulously and a bandage contact lens is applied. The post-operative photo shows a clearing of the macrostriae with significant visual improvement. The second case presented on the third post-op day with flap slippage and flap folds. Here, the stromal bed is exposed with epithelial ingrowth. In this situation, the epithelium over the exposed bed is meticulously removed with a hockey stick knife before lifting the flap. The flap is lifted. The folds in the flap can be best addressed only by removal of epithelium on the surface. So the epithelium is completely removed on the flap surface as well. The flap folds are stretched using two dry merosal sponges. The bed is washed to remove epithelial nests. Flap is replaced and smoothened with a wet sponge. Four 11-0 nylon sutures and one 10-0 nylon suture was applied to keep the flap in position. Then a bandage contact lens is placed. This case highlights the importance of preventing epithelial ingrowth in such situations. The post-operative picture shows a smooth flap with a good return of visual acuity. The third case shows a similar situation with a flap slippage with dense flap folds and epithelial ingrowth. A merosal sponge is used to completely remove all epithelium on the exposed stromal surface and a 2 mm margin around the flap. Flap is floated into position. The epithelium on the surface is also removed to facilitate the removal of striae. Stretching the striae is done using two dry merosal sponges perpendicular to the direction of the striae. Flap is replaced after completely washing the interface. Fourth case shows a completely displaced flap with rolled edges. This video shows the importance of removing epithelium under the surface of the flap in addition to the stromal bed. The rolled up flap edges are gently scraped off the epithelial ingrowth and replaced. Suturing the flap is mandatory in this situation to prevent repeat flap slippage and epithelial ingrowth. Femtoflaps show less incidence of flap displacement and striae due to better fitting of the flap on the bed. However, this femtoflap shows radiating flap striae originating from the hinge. The epithelium over the striae is removed after lifting the flap. The striae are stretched perpendicularly. The flap is replaced on the bed after thorough washing of the interface. The pre-placed marks show a significant shift after realignment of the flap. In cases with visually significant striae, early intervention, meticulous removal of epithelium from stroma, application of suture, and bandage contact lens gives best results. Our series of patients improved with simple stretching of the striae using dry merosal sponges. In case of refractory striae, PTK and Donenfield method of hyperthermic ironing of the flap using heated spatulas has also been recommended. Flap striae are better prevented than managed. Examination of the flap at 20 minutes post-operatively is recommended to ensure the flap has not slipped out of position. Careful and precise positioning intra-op is mandatory. Good counseling and need for adequate protection during day and night prevents and lowers the incidence of flap striae.
Thank you, Sujata. I think that was again excellent presentation. Various ways of managing flap striae and very difficult cases, I think, to do. So, any comments on this? I think this was the last talk because Dr. Partha has not joined.
Amazing presentation, Sujata. Really wonderfully shown and lot of teaching pearls.
Like a master class.
Yeah, it was like a master class.
I just have one question, Sujata. What is the longest period that you have addressed flap striae? Because it is said the earlier you do it, the better. So, for how long, they will? Huh?
1 month, up to 1 month later, it was a referred case. Normally, if I see a striae, I would go in immediately. But this was a referred case. And so after 1 month, I intervened. And that was the longest period.
Okay, so I think if there are no comments, sir, we'll serve dinner some other time.
No, I was just joking.
To all the,
Nothing serious.
or to all the. I
Actually,
hope we
she
next time do
took
it.
seriously.
No. I'm sure we'll do something physically next time, and then we will have lunch or dinner, whatever, for a refractive session.
Dr. Titala not served dinner to chief.
So thank you, everyone. I think it was a great session, and each of the talks were really very nice, very innovative, and very illustrative. I would like to thank everybody in the panel, and thank you for joining this session. And I would also like to thank the audio-visual team, which is there, Ravi Grover, Mr. Ravi Grover, and Mr. Kripal Rana, who have helped to make this entire program. And we have close to 20 international societies. And more importantly, the international delegates who have registered is far greater than the national registrants, mainly because we send the link to all the international societies. So this was a new dimension which we wanted to add, that is to have the participation of the international delegates as well. So thank you, everyone, for this great session, and looking forward to meeting you tomorrow again. Thanks.
Thank you.
Thanks for a wonderful session. It was very enjoyable.
Yes, really enjoyed it. All the talks.
Congrats. Well done.
Thank you.
Thank you.
Thank you. Good night, everybody.
Thank you. We are going offline. See you tomorrow. Thank you.